Good morning. I'm Tomlin Paul, Dean of the Faculty of Medical Sciences at the University of the West Indies here in Mona, Jamaica. And I'm very happy to welcome you to our teleconference, COVID-19, Making New Year Resolutions. I had the pleasure of welcoming you back in 2020, March 5, 2020 it was, when we had our very first Faculty of Medical Sciences teleconference. And since then, a lot has happened. At that point, in fact, we had no confirmed case. We had not yet had a confirmed case of COVID-19 in Jamaica or in the Caribbean. And since that time, we have had a few teleconferences ourselves. The wider university has had a range of meetings and seminars and workshops on COVID-19. In fact, the 3 teleconferences that we ran from the faculty, to date, we have had over 58,000 views. And I want to say more staggering than that, those numbers are quite encouraging, but more staggering than that, since March the 5th, we have had 95 million plus cases of COVID-19, and we have had over 2 million deaths. Very heartbreaking data for us to consider. But we're not daunted. As we enter 2021, we come from the University of the West Indies today, rekindling our hope and bringing new resolutions to the table in this fight against COVID-19. So our conference today brings new resolve with respect to this pandemic. There's much new to talk about, and our conference program will bring these updates to you this morning and later on this afternoon. We will start the discussion on what does the pandemic look like now? Is there a new phase? Pandemics have characters of their own. And we want to look again at the COVID-19 pandemic, and Professor Peter Figueroa will bring that picture to us as we start the ball rolling this morning. We also have another new phenomena occurring around us, the question of new variants, new strain. Is the virus looking the same as it looked on March the 5th? What is it looking like now? What else is happening in terms of variants? And our very own Dr. Sandra Betty-Jackson, microbiologist here at UWI, will speak to that. We also will take a look at the clinical features and outcome with respect to COVID, the disease itself. We understand as we look at the natural history of all diseases, we get a better picture, we get a more refined view. And so we want to bring you up to date on what the disease phenomena picture clinically and the outcomes really look like at this point in time. We're going to take a look also at the special populations. COVID-19 has brought to fore the vulnerability of special groups. We talk of the older persons, we talk about those with pre-morbid conditions, and so we're going to look at what has happened over time with these groups, any other special new groups, certainly the pediatric group, the children are of importance, and Professor Denise Eldemire-Shearer will look at the care for special populations and COVID-19. And then the biggie that when the pandemic struck, we were looking at treatments, and there were all kind of treatments being put forward. And now we want to update you. Are there treatments that are now confirmed? Do we have medication that really work? What is the treatment strategy for addressing COVID-19 as we go forward? We will now also look at new treatments and new knowledge that has come to fore. With respect to the vaccines, which is also new on the table, we are getting ready for bringing that shot, the vaccine shot. Are you ready for your vaccine? Are you ready for the COVID shot? And Professor Celia Christie will speak to that this morning. And lastly, the economy. Is there a new COVID economy? Is there a challenge in terms of the economics and our operation? What is the impact of COVID-19 on the economy? Dr. Christine Clark from our Faculty of Social Sciences here at Mona will bring that discussion. Last but not least, we want to leave you with some new hope. And we ask the question, when will all of this end? And within that, how do we find hope and keep resilience alive as we go forward? And Professor Wendell Abel, who is one of our veterans for these teleconferences, will be speaking to you this morning. So we welcome you once again, our Vice Chancellor, Sir Hilary Beckles, and our COVID-19 task force of the university also welcomes you. In fact, our VC said in his December greeting to us that the post-COVID university will be a very different kind of academy, fully embracing communications and production technology in order to be agile in capturing opportunity. And this is what we're doing this morning. We are following the guidance of our Vice Chancellor as we bring this teleconference to you this morning. We're delighted to welcome you, and we bring greetings, and we look forward to a successful and engaging teleconference. Our first speaker this morning is well known in the Caribbean region, and certainly here in Jamaica and internationally, for his work in public health, epidemiology, and HIV/AIDS. In fact, during the early phase of the HIV/AIDS pandemic, this speaker was well engaged doing really on the front line in terms of work at the epidemiological public health level here in the Caribbean and in Jamaica. He was recognized in 2019 by the World Health Assembly as a health leader. And that encapsulates really, what I can tell you a lot more about him, but I think that recognition speaks to the person that we have before us who will speak on the COVID-19 pandemic, give us an overview, local, regional, and international. Let us welcome Professor Peter Figueroa to the podium.
Thank you, Dean Paul. I am going to give an overview on COVID. Just to declare interests, I have no financial interests. However, I'm a member of the World Health Organization SAGE Working Group on COVID vaccines, as well as chair of the PAHO Technical Advisory Group on immunization. I'm going to give a brief overview of the pandemic, touch on the clinical and epidemiological features, and then focus a bit on the vaccines and some of the challenges that we face and actions needed. As Dean Paul said, we now are faced with over 95 million confirmed cases of COVID and 2 million deaths. We have crippled economies across the globe, as well as disrupted lives, livelihoods, and social life. At the same time, we must not lose sight of other significant problems. Every year, as many as 1.5 million persons die from tuberculosis, and we don't make as big an issue of it, partly because this is restricted primarily to a number of small, poor countries, or large, poor countries. So we need to bear this in mind, that we still have many problems in addition to COVID. If we look at the reported deaths, it's in the United States where we see most confirmed cases and most deaths, as many as 400,000. India has over 10 million confirmed cases, 150,000 deaths. Brazil, 8.5 million cases, over 200,000 deaths. It is amazing that in China, with a population of over 1 billion persons, appears to have less than 100,000 cases and only 5,000 reported deaths. Here in Jamaica, we have over 14,000 cases and just over 300 deaths. So the case fatality rate is approximately 2%, a little above, a little below, depending on the setting. But the overall confirmed cases globally are likely to be underreported. Now, there are basically 3 strategic approaches to controlling the COVID pandemic. You have those countries that have embarked on decisive control measures. China, New Zealand, Vietnam, they have aggressive testing, treat, isolate, contact tracing, quarantine, masks, physical distancing, and they have lockdown where required. In Jamaica, we have a more measured approach where we take the non-pharmaceutical measures and we promote them and implement them. Some countries have initially embarked on trying to achieve herd immunity, or they have been in denial, and they have minimal national measures. I will not comment on the approach taken in the United States, which unfortunately has meant that they have had far more deaths than they really should have had. The challenge we face now is not just the economic hardship and the disruption to social life, but persons are beginning to develop what we could call COVID fatigue, and unfortunately, some of them are resisting the required measures. But there is hope. Once we can get equitable access to effective vaccine, there is hope. Now, there are some impressive lessons. I just want to touch on what we can call the unprecedented public health response in China. It's perhaps the most ambitious, agile, and aggressive disease containment effort in history, according to the WHO China Joint Mission report of March 2020. Not only did they have universal non-pharmaceutical measures, but they suspended public gatherings. The people adhered to the containment measures, and there was massive mobilization of volunteers throughout the country. And their bold approach has changed the course of the epidemic in their country. Local officials were slow in reporting the outbreak initially, but once they isolated the coronavirus, they sequenced the genetic code within 1 week and shared it internationally, which meant that within Germany, in another week, they were able to develop a diagnostic tool, which we use in Jamaica right now to do the PCR test. And in China, with their aggressive testing, isolation, and treatment, they control the epidemic. They built 2 new hospitals in 2 weeks and set up isolation areas in a number of stadiums. Total lockdown of a town, Wuhan, of 11 million, mobilized 40,000 health providers from across China. And really, it was a very impressive control program. I think we all now know the clinical features of COVID, and another speaker is going to go into this. But many persons have fever, cough, fatigue, shortness of breath. But what is interesting is the loss of smell or taste is often a signal event of COVID. 80% of persons who develop symptoms of COVID are going to have a mild or moderate case, and they will recover. 14% approximately are severe, and unfortunately perhaps 6% of cases are critical and require very aggressive supportive treatment. Fatality increases significantly with age. Now, the incubation period, that is the period from exposure and infection to the development of symptoms, is usually 1 to 14 days, but most times between 5, 6, or 7 days. And then now, persons who do develop symptoms, you have to be careful at day 7. Some people become significantly worse, approximately at day 7. Others are on their way, the majority are on the way to recovery. We are now seeing what is termed long COVID, where symptoms may persist over 4 weeks. Often it is fatigue and muscle weakness, just tiredness. Sometimes some difficulty breathing or tightness or cough. And there are a range of other symptoms that you will hear more from another speaker. We know the measures to prevent COVID. Wearing masks makes a difference. Physical distancing is important, as well as stay-at-home measures. Avoiding and restricted crowds, especially indoors. Hand hygiene, aggressive widespread testing, intensive contact tracing, isolation of cases, quarantining contacts, and where needed, closing restaurants, bars, even schools, and where necessary, either local lockdown or total lockdown of a country. We know it's person-to-person spread primarily, mainly from persons with symptoms. But before people are aware that they have symptoms, they are able to transmit in the preclinical phase or with minimal symptoms, as well as asymptomatic persons can transmit. The virus can survive on surfaces, so you do have to be careful that you don't contaminate your hands and then contaminate yourself by touching your face, your mouth, your nose, or your eyes. When we look at some curves that look at the deaths per million residents, we can see that this rate is probably highest in the United States. And you can see it is relatively low in a country like Japan, with Europe and Canada in the middle. If you look at the number of daily new coronavirus cases per million residents, you can see a similar pattern among countries. Now, once you have a surge in COVID cases, you go, and that is shown in blue, you're going to get a surge in the number of severe cases requiring hospital, shown in red. And what follows approximately 3 weeks later is a surge in deaths. And this is why public health authorities want to prevent a surge in cases. And this is why people must adhere to the non-pharmaceutical measures in order to prevent a surge, which invariably leads to increased severe cases and more deaths. So we now know that we're having a serious surge of cases, not only in the United States, in North America, also in Britain, in Europe, in South Africa. We are seeing a serious surge. Some of this is due to the fact that the temperate countries are now entering the winter period when respiratory viruses transmit more readily. But also, we are seeing new variants of the SARS coronavirus 2. So the virus that causes COVID is an RNA virus. It tends to mutate. Most of the mutations actually die out. However, there are variants that have what we call enhanced viral fitness. They can spread more readily. And this is what has been seen recently in Britain. One was circulating from around September, and we've seen it in South Africa, and there are possible other more virally fit variants. What is encouraging so far is that it appears that they do not cause more serious disease, but this has to be monitored closely. But again, you see the importance of the masks, the physical distancing, the avoiding crowds. Now, COVID pandemic has had a serious impact on the rest of the health services. I just use one example of childhood vaccination in the Caribbean. The negative impact of COVID, it has meant a decrease in the number of children being vaccinated, both for diphtheria, pertussis, tetanus, as well as measles, mumps, rubella vaccines. Now, it is very encouraging that with the pandemic, there has been a significant global collaboration to accelerate the development of diagnostic therapeutics and vaccines to control the pandemic. And the Access to COVID Tools Accelerator was launched in April by the World Health Organization, the Gates Foundation, and a number of European countries. And the aim is for this global collaboration to speed up efforts to end the pandemic. And this is important because we must ensure that there is equity of access to the measures that will help us to better treat and prevent spread of COVID. Let's look at the lessons, 3 lessons from the past. In 2009, there was a H1N1 influenza pandemic, and the flu vaccine was used in high-income countries to control it. But there was very little availability of this flu vaccine in low and middle-income countries. And this is despite the fact that many of these countries, including Jamaica, are part of the global influenza network that contributes viral samples to the development of influenza vaccine every year. So we've got to avoid this kind of inequity across the globe. In 2014, there was an Ebola outbreak in West Africa, and the World Health Organization was slow to mount an effective response. We have to respond promptly to pandemics. 2017, the Ebola outbreak in DRC, the country and WHO responded decisively. There were over 3,400 cases of Ebola and over 2,000 deaths. They used a new vaccine to control the epidemic. However, they failed to sustain routine immunization, and therefore there was a massive outbreak of measles, over 300,000 cases, resulting in over 6,000 deaths, nearly 3 times the number of deaths due to measles than to Ebola. So while we work on COVID, we cannot take our eye off other essential health services. Back to what the Access to COVID Tools Accelerator Global Collaboration is aiming to do. Wants to get diagnostics of our high-quality rapid test to 500 million person tests in low and middle-income countries by the middle of this year. 250,000 therapeutics and 2 billion vaccines available by the end of this year, and to ensure equity of access to those most in need. So one of the pillars of the Access to COVID Tools Accelerator Global Collaboration is the COVAX facility, the Corona Vaccine Access Facility. And this is supporting the vaccine development and manufacturing activities with the aim to end the acute phase of this pandemic by the end of 2021. Already 189 countries have enrolled in this COVAX facility opportunity. They're self-financing countries that have paid down on getting vaccine, nearly $5 billion paid down already. And then there are 92 countries that are eligible for advanced market commitment. Because these countries are low income, they are eligible for developmental assistance funds. However, $5 billion still needs to be raised to ensure that these countries also get ready access to the vaccine. And the aim of the COVAX facility is to promote equity of access. So no self-financing country will receive doses of vaccine to cover more than 20% of its population until all self-financing countries have been offered doses. Now, this is a WHO slide which just tries to capture that the SAGE, this is the Strategic Advisory Group of Experts, a team of independent experts who advise the Director General of PAHO. They help him to elaborate policy. And there are a number of working groups under the WHO SAGE group, the advisory group, and they have developed the values framework to identify the principles and objectives on which we should allocate the vaccine. And then there's a roadmap which identifies the priorities. And then there is another group which looks at each candidate vaccine and makes recommendations to the Director General whether the vaccine is suitable, whether it is safe and efficacious. This is just a quick summary of the values framework, which the goal of which is to ensure that COVID vaccines are a global public good, so that we respect all equally, promote human well-being, promote global and national equity, and recognize reciprocity as well as legitimacy. The roadmap targets health workers at very high risk and older adults to get the vaccine first. We do not have time to go into the roadmap in any detail, but we could say that the rationale for vaccinating health workers at risk is because they're critical to preserve the health service. Health workers are at high risk of getting COVID, as well as if they get infected, they will pass it on to their patients. And there's the principle of reciprocity. Health workers who play a critical role in the response, work under challenging conditions, putting themselves and their households at risk, and working for the sake of others, deserve to get the vaccine early. Now, this can also be argued for other essential frontline service workers. When it comes to the rationale for vaccinating older adults, you have to bear in mind, and this graph attempts to show, that the infection for fatality rate increases significantly at older ages. Perhaps a quarter of persons over age 80 are going to die from this disease, and perhaps 15% of those over 70. And comorbidities also increase with age. So if you target the elderly, you're helping to save lives. But there are other vaccination strategies that you have to bear in mind depending on your situation. Indonesia is using a vaccine from China, which when they did the trials, they did not include sufficient elderly persons. So they don't have the evidence to show that it works in the elderly. It probably does, but they have taken the decision they're going to target adults 18 to 55, hoping to achieve herd immunity and protect the older and the younger that way. Some may choose to identify essential workers to keep the economy going, because remember, many of the elderly can continue to stay at home even for 6 months more while other essential workers are being vaccinated. Now, one of the big challenges with equity of interest is that many of the high-income countries have contracts pre-ordering vaccine from the pharmaceutical companies. It's estimated that there may be about 7.5 billion doses of vaccine available this year. But bilateral agreements among a limited number of countries account for 7.4 billion doses. 2 billion of these doses are contracts with the COVAX facility. But this is a potential issue that undermines the equity of access of vaccines. You also have to think of strategies to manage the vaccine shortage, because even next year, early next year, there will be a challenge with the shortage of vaccines. So you need to deliver all the available vaccine to the field. There's a big discussion now, and I think the majority of experts are seeing the potential value of delaying the second dose of the vaccine. You can't delay it excessively long, but you can delay it for a period. We can explore the use of a fractional dose. We can mix and match different vaccines. And we need to accelerate the development of the most promising one-dose candidate vaccines. In all of this, research must play a critical role, and we must maintain the non-pharmaceutical measures. We do have many challenges. Many low and middle income countries do not have a ready platform for vaccinating adults. It may not be easy to identify and mobilize those targeted for the vaccine, the elderly and those with comorbid conditions. People must have confidence in the vaccine to take it. The vaccine characteristics will vary. There are different issues of storage, cold chain, logistics. You're going to have to mobilize and train additional staff to give the vaccine. And it's going to cost additional money. And it's a time of economic downturn. And there are significant opportunity costs if other essential services are not sustained. Some people articulate concerns with the vaccines, that the development has been too rapid, that the trials are too short to assess safety, and concern about these new messenger RNA and DNA vaccines instead of the traditional inactivated or attenuated vaccines. How long will vaccine efficacy last? The virus is mutating. Will it escape from the vaccine? And there are a variety of conspiracy theories. What many people do not realize is that scientific efforts to develop a vaccine to the coronavirus has been going on for decades. When we had the SARS outbreak in 2005, this gave a big push to stimulating research into a vaccine against the spike protein of the SARS coronavirus. And there was another push following the Mediterranean respiratory syndrome outbreak in 2012. So once the genome was sequenced, it meant that those people working on a vaccine for coronavirus were simply able to take the genomic code and prepare a vaccine immediately and put it into vaccine trials. What many people do not realize is that many of the biggest technological breakthroughs in American history have not sprung from the private sector. They've been the result of collaboration between private companies and federal governments. So although you hear all the different vaccines coming on board are being pushed by private pharmaceutical companies, a lot of public state-funded research, federal research, funding, and research has gone into the development of these vaccines, just as it went into its government research in the United States that led to a whole range of very everyday developments and initiatives, including the internet, jet airplanes, transistors, silicone chips. So we need to bear this in mind. Partnership is what makes a difference. There have been vaccine trials covering thousands of persons. So bear this in mind. There is no candidate vaccine that can be brought to the human population without it being carefully carried through a series of vaccine trials. The characteristic of the new platform, messenger RNA vaccines, these cannot, they use a nanoparticle, a lipid nanoparticle, which is very, very small. It's taken into the cytoplasm of the cell. It does not enter the nucleus or the genome of the human cell. It's broken down rapidly, and it stimulates antibodies. It produces a protein that stimulates antibodies to the spike protein. So the trial results are very encouraging. Efficacy is high. They appear to protect the elderly, and the safety profile is encouraging. As they rolled out the Pfizer vaccine, they did notice that on uncommon or rare occasions, people had severe allergic reactions. So anyone who has a history of anaphylaxis reaction to a vaccine, injection or a vaccine, should not take the Pfizer vaccine. And everyone should be observed for 15 minutes. When will the vaccine become available to countries in the Caribbean and elsewhere? It may not be until a small supply in April and then more towards the end of the year. We still have many important issues to address because we don't know the duration of vaccine efficacy. The effectiveness of the vaccine may decline or increase over time. Different vaccines have different characteristics. So a vaccine may be able to prevent someone be getting severely ill, but that person may still become infected and be able to transmit the virus to others. So we need to promote vaccine confidence among health workers and the population. A few final reflections. We're going to have to live with COVID for the foreseeable future. Vaccines are not a silver bullet. We're going to continue to have to use non-pharmaceutical measures. We need better rapid point-of-care tests. Saliva tests have been developed. They need to become available globally. Dogs can be trained to smell persons with COVID, just like how they smell persons who are carrying drugs. There are apps that can help to inform someone whether they have been exposed. We're going to continue to learn more about COVID. We have to prepare for more change as the situation is dynamic, and we have to be patient. The scientific community and the governments are getting there with the measures that we need to control the pandemic, but it's going to take a little more time, and everyone needs to play their part in ensuring that we protect one another. I would suggest that you take the vaccine when you get the opportunity. I, for one, am certainly going to. Thank you.
Thank you very much, Professor Figueroa, for a very informative overview. Really what we're hearing this morning, colleagues, is a picture of the epidemiology, again, of COVID-19, where we have reached with the profile of the pandemic. And this overview today, we had the extended discussion on the public health aspect. So we hear of things like the COVAX facility, the immunization strategies. We heard about issues of equity, which are very important as we take on the pandemic at this phase. The questions of are all countries and persons even being treated equal in terms of access to care, access to the vaccines, etc. We heard some stuff about the viruses and the variants, and we'll hear about that later on in the conference as we go forward, and a bit on the clinical features, which we'll also be taking on in short time. So I really want to say thanks to Prof. Figueroa again for an excellent talk, for getting the ball rolling, getting us off the bat, and taking us into some thinking about our resolutions for 2021 with respect to COVID-19. I don't know if any of you saw, but he made one last call for us to make a resolution at the end, and that is we should all consider taking that vaccine when it comes. So that's a resolution that you can put in your list, add that to your 2020 resolution that you will be considering. And he did say, depending if you're allergic and so on, but make sure you look at taking that COVID-19 vaccine. Thanks again, Prof. So as we continue our COVID-19 teleconference, making New Year resolutions, we have heard from Prof. Figueroa, that overview, and we want to hear a little bit more now about the viruses and in this new year where we are. Now, a lot of you know, we're familiar with COVID-19. That has become like a household name, COVID-19. And what we're doing here is we're reconnecting this syndrome with the etiology, with the cause, and that's the virus. And we hear of the virus, and in fact, some of you may not be directly in the medical microbiology field. You hear of SARS-CoV-2. And we're already talking about, when we say SARS, the severe acute respiratory syndrome, that's the abbreviation we use, coronavirus. So we really here now, this topic we're going to look at is, we talk about new variants, and is it more of the same? We hear that we have had some new, so I would say variant strains, new strains, and are we looking at something that's really dangerous, something really new? How many, how different, where do we have it in the Caribbean? There's lots of questions behind this, this phenomenon. And I'm very happy to introduce one of our veteran speakers who has been before with us on our teleconferences. And Dr. Sandra Betty is a microbiologist. She's a medical microbiologist, and she's also a clinical virologist and a public health consultant. She has served as the director of the National Influenza Center based at the UWI for over 15 years and has expertise in molecular technology and influenza detection. In fact, she's a subject expert in influenza virus traceability mechanism, which helps us to monitor the influenza viruses and pandemic potential. And that, therefore, she's more than equipped to come and speak to us today. The work she has done in influenza, the work in viruses, infections, and so she's going to bring that expertise today to throw some light on this little virus that we can barely see with the naked eye. And then we ask the question, boy, are they looking different? Are they new strains? So let us welcome Dr. Betty, as she speaks, a close look at the new SARS-CoV-2 variant strains. Is it more of the same?
Thank you, Dean Paul. And thanks to the Faculty of Medical Sciences for inviting me to come and present today. As we look at the topic, SARS-CoV-2 variant strains, is it more of the same? There are many questions that many of us ask and seek answers to. This talk will address some of the reports in the forms of objectives, looking at review of reports of unusual public health events, possibly due to variants of SARS-CoV-2, which have been reported to the World Health Organization. We'll review the international and national authorities' methodologies in their assessment of variants of SARS-CoV-2 to determine changes and its effect, and look really what is the impact of these or the implications of such variations on the transmissibility of the virus, on the clinical presentation and severity, in particular with potential impact on countermeasures, on diagnostics, on therapeutics, and on vaccines. As we look on this slide here, we refer back to the well-known schematic diagram of the coronavirus, which is showing us some important features of the characteristics of the virus structure here, including the spike protein, which is very critical in the virus attaching to the receptor in the human host cell. Going back a little bit on the human coronavirus types, we know that, just to refresh us, that the coronaviruses are divided into 4 subgroups called alpha, beta, gamma, and delta. And 7 of these subgroups have been found to circulate and to infect humans. 3 causing more severe disease, the more recent one, SARS-CoV-2, and also some others that have been described previously that were associated with the common cold, such as 229E, NL63, OC43, HKU. But MERS-CoV-2, SARS-CoV, another beta virus, and SARS-CoV-2 are the 3 more recent emerged coronaviruses that have been associated with increased morbidity and mortality. And this is just the larger diagram showing you the different groups here, but why I'm displaying this is also to show you that within the mammalian group, it's not just these 7 viruses that circulate among humans that we need to be concerned about. There are other coronaviruses that circulate among other animals, such as in bats, in pigs, in cats, dogs, mink. So there are hundreds of coronaviruses, and it's only a few of them that actually infect man. Now, researchers isolated the virus causing pneumonia in China in December 2019 and found it to be one of these beta coronaviruses. The virus showed a high nucleotide sequence similarity or homology to other coronaviruses known to be derived and found in bats and related to the coronavirus that was associated with the SARS outbreak, severe acute respiratory distress syndrome outbreak, and also the MERS virus, Middle Eastern Respiratory Syndrome coronavirus. So this new coronavirus, SARS-CoV-2, was found to be associated most similarly, as in this slide, which I revert back to the latter three coronaviruses. So what has happened since then? So now, although named SARS-CoV-2, it is the causative agent of COVID-19 disease as we know it. The virus is a positive RNA, single-stranded RNA virus, and it's a very relatively small virus, 30 kilobases, and encodes for 10 genes. It enters the human cells by binding to the angiotensin converting enzyme 2 through its receptor binding domain in the spike protein, which I referred to originally. So just looking back here, we see that bats, in terms of the evolution of coronaviruses and the ability of the coronaviruses to infect other animals, and also we see here where the SARS-CoV-2 virus actually lies in the evolution of this virus. Now, what are variants, clades, and subclades? Generally, the genetic variations of a virus are grouped into clades, which can also be called subtypes, genotypes, or groups. In virology, a clade can be referred to a group of similar viruses based on their genetic sequences. Genetic changes in viruses can also be tracked using phylogeny, and rapid genome sequencing is the method by which developments in a virus's genomic makeup can be traced or tracked. SARS-CoV-2 itself is a clade within the coronavirus Viridae family and the genus of the beta coronavirus. So what are some of the factors that promote mutations in viruses in generally? And let me refer to RNA viruses. These tend generally to be more unstable than DNA viruses and are more prone to mutations. Community transmission of viruses, ongoing replication of a virus within a community is one of the factors that promotes mutations of virus. Antiviral treatments can promote novel mutations in a virus, potentially resulting in more virulent strains with higher mortality rates or the emergence of strains resistant to treatment. Therefore, systematic tracking of demographics and clinical patients' presentations is important, and strain information is indispensable to the efficacy of combating the COVID-19 pandemic. WHO analyzed SARS-CoV-2 genomes from over 10,022 samples to understand the variability in the genome landscape and to identify emerging clades. The WHO study used sequence data established SARS-CoV-2 reference genome that was sequenced in December 2019 as a reference virus. As we take a closer look here at the different clades that have evolved over time and looking at the timeline at this tree, at the phylogeny, we see there are 5 main clades here: G clades, S, O, L, and V. And we see in the earlier part of the pandemic, at the beginning, it was mostly clades V, L, O, and S that were predominant. And as time progressed, we see more of the evolution of G clades, and G clade thus being further divided into subclades. In late January or early February 2020, a variant of SARS-CoV-2 with a mutation of D6114G substitution in the gene encoding the spike protein emerged over a period of several months. In May, this mutation, the D614G, replaced the initial SARS-CoV-2 strain identified in China, and by June 2020 became the dominant form of the virus circulating globally. Studies in human receptor cells and in animal model cells showed that compared to the initial virus strain, the strain with the D614G substitution has increased infectivity and transmission. The SARS-CoV-2 virus with the D614G substitution, however, does not cause more severe illness or alter the effectiveness of existing laboratory diagnostics, therapeutics, vaccines, or public health measures. In May 2020, following a publication from the Bulletin of the World Health Organization with more detail on the D614G variant, it was shown to be located in the B cell epitope with a highly immunodominant region that may therefore affect vaccine effectiveness. Although the amino acids are quite conserved in this epitope, 14 other variants beside D614G were also noted. All strains of the D61G mutation also have a mutation in the protein responsible for replication, that's ORF1AB, and which might affect replication speed of the virus. This protein is the target of antiviral drugs, remdesivir, favipiravir, and the susceptibility for mutations suggests that treatment-resistive strains may emerge quickly. The other mutations detected included the V483A and the G476S, and these are primarily observed in samples from the United States, whereas the V367S is found in samples from China, Hong Kong, Special Administrative Region, France, and the Netherlands. The V637F and D634Y variants have been reported to enhance the structural stability of the spike protein, facilitating more efficient binding to the ACE2 receptor. GISAID, which is one of the main platforms on which reports and does analysis on the genomic sequences of the SARS-CoV-2 protein, looking at more recent virus genomes that have been uploaded to this platform. In 182 of them were found to be from the GH clade, of which 89% had 3 mutations in the spike receptor binding site, and these are noted as the K419, 4179, E484K, and N501Y. 27% of the 182 had 9 nucleotide deletions in the NSP6, in addition to 3 mutations. And spike mutation N50Y was found to be also associated with the novel variant now described from the UK. And this is different, this is from a different clade. 71 of the 182 that were analyzed, 71 are from the clade GR, 45 from the clade G, 1 from clade G, subclade GV, and 2 from other clades. So as we review this, the evolution again, we see here, and maybe we can better understand the evolution of the G clades, and you can see that the G clades and subclades have become more dominant, replacing the original clades that were detected in late December, the earlier part of 2020, and now in the latter part of December 2020 and 2021, we have a predominance of the G clades circulating. In this map, it just shows the distribution globally. again, and you can see predominance of the G clade and also its subclades. Within the different WHO regions, North America, Europe, Asia, South America, Africa, and Oceania, and this information is taken from the GISAID platform, we see that there is variation in the distribution of the clades in the different regions. Some having predominantly, some still having subclades associated with GV or GH, whereas others having less of the G clades circulating at this point. In August and to September 2020, another variant was detected, and this variant was associated with mink farms. And the variant was linked to infection among farmers working on this on properties, and this cluster was also identified and reported by the Danish authorities to have a combination of mutations not previously observed. It was noted that these mutations may result in reduced virus neutralization in humans, which could potentially decrease the extent and duration of the immune protection following natural infection or vaccination. However, Danish authorities have identified only 12 human cases of cluster 5 variant in September 2020, and it did not appear to spread widely. However, they culled millions of mink animals as a result of this. Following this, in December 2020, the United Kingdom reported to WHO another variant, and this variant is termed Variant of Concern, year 2020, 12 for the month 12, and variant 01. SARS-CoV-2 VOC 2021-1201. Of interest, this variant has 23 nucleotide substitutions and is not phylogenetically related to SARS-CoV-2 virus circulated in the United Kingdom at the time that the variant was detected. So this is a new variant with many more nucleotide substitutions than previously detected. How and where this variant originated is not clear. It initially appeared in southeast England, but within weeks began to replace other virus lineages in this geographic area in London. And preliminary epidemiological modeling and phylogenetic and clinical findings suggest that SARS-CoV-2 variant 2021-1201 has increased transmissibility. However, preliminary analyses also indicate that there is no change at this point in disease severity. Another of the mutations found in this variant, UK variant, is the deletion at position 6970. And this is found to affect the performance of some of the diagnostic PCR assays, such as assays that use the S gene target. However, most PCR assays worldwide will use more than one target, and therefore the impact of the variant on the diagnostics is not anticipated to be significant at this point. Laboratory evaluation has demonstrated no significant impact on the performance of antigen-based lateral flow assays as well. As of the 30th of December, the SARS 2021-1201 variant had been reported in 31 other countries, territories, or areas in 5 of the WHO regions. This is just a schematic diagram showing the 3D structural visualization of the spike protein with mutations. And here, this is the UK variant, and we can see the key mutations here, and they're noted as we have 10 here. Shortly after this, another variant was reported from South Africa, and we see this variant has 7 key mutations, of which the D614G is also present. However, it is different from the UK variant that was reported before. While SARS-CoV-2 variant from the UK also has this 501Y mutation, phylogenetic analysis has shown that the South African variant, which is termed 501YV2, is different from the UK. This new SARS-CoV-2 variant has largely replaced other SARS-CoV-2 viruses circulating in the Eastern Cape, Western Cape, and KwaZulu-Natal provinces. It is associated with a higher viral load, which may suggest potential or increased transmissibility. This, as well as other factors that influence transmissibility, are subject to further and ongoing investigation. Moreover, at this stage, there is no clear evidence that this new variant in South Africa is being associated with more severe disease or worse outcomes. When we look at a summary of the key variants of concern worldwide between September 2020 and January 2021, the variant designations, looking in the first row here, is the first identification, the B117 lineage, reported from the United Kingdom in September 2020. The characteristics of the mutations are noted here, and the number of current sequences, confirmed cases in other countries include 76 in the United States and 15,000 plus worldwide. So the number of countries with this B117 variant presently is at 36. We also have from South Africa, the South African variant has not been detected presently, not up until today, in the United States, but worldwide 415 cases have been detected, and the number of countries with sequences being uploaded, 13. And then we also have additional variants that have been reported from Brazil and Japan. And these have been found in 35 countries worldwide, and with 2 countries so far within other countries uploading sequences related to this variant. If we look generally at the map of tracked variant occurrence, this is of the UK strain, we can see how rapidly it has spread. So when it was announced that the possibility of increased transmissibility of this virus was a risk factor, we are seeing it evolve as we speak here, with the variant being detected in other countries, many other countries worldwide. This is not an exhaustive list, but I included it as we have the Jamaican strain here also listed as one of the countries now having detected this new strain. That's JAM 47452 2020. In January 2021, United States yet announced other variants being detected, and these were but however, most of the variants are related to the B117 lineage that was detected in the UK. Following this, CDC's system for genomic surveillance has increased, and they're inputting many efforts to expand the sequencing capacities of laboratories there to increase the availability of the timely US genomic sequence data so they can be better tracked. So what are the implications for public health practice as the CDC reports? This increased transmissibility of the B117 variant warrants universal and increased compliance with mitigating strategies, including distancing and masking. Higher vaccination coverage might be needed to protect the public. Genomic sequence analysis, though through National Surveillance Program, will enable a better targeted approach in identifying the variants in the United States. Following this, WHO, I know, is also embarking on the similar trend to increase the capacity building of sequencing in different countries worldwide. And if we look at the map of the US here, we can see the darker blue regions indicate a higher detection levels of the B11 lineage. And you can see how rapidly it is spreading. Of interest, the CDC also published this, the simulated case incidence trajectories of current SARS-CoV-2 viruses and the B117 variant, assuming that the communities are vaccinated and an initial reproductive number of 1.1 or initial R of 0.9 for current variants. So if we look first at, this is assuming the community is vaccinated. If we assume the community, the gray area is the total. The current variance is indicated in the dark blue, and the light blue shaded area is the emergence of the B117. And so this is with the population being immunized. You still see that there still will be an increase in the transmissibility or detection of this new variant, while concurrently a decrease in the existing strains is expected to occur. If the reproductive number is less than 1, 0.9, we see a big change, a significant change in the trajectory of the transmissibility of this infection here. Because we see in the total number will decrease significantly to the total number of reported cases. The number of current variants will also decrease, and it will impact positively by decreasing the number of the emergence of the number of B117 variants detected. So I thought that this was an important slide put out by the CDC because it shows the importance not just of vaccination, but of maintaining the different mitigating procedures that many countries nationally have implemented, such as social distancing and mask wearing. It has to go hand in hand with vaccination. So assuming no vaccination takes place, this is what will happen. The total number of cases will continue. The B117 lineage will increase significantly, okay? Although the current circulating strains that were originally detected at the beginning of the pandemic, those will decrease somehow. This is assuming no community vaccination and with a reproductive number of 1.1. But however, with a RO of 0.9, we see a significant decrease in the transmissibility. How do the introduction of these variants also affect other aspects, such as the diagnostic capacities? We can see most of the PCR, we did not go into the details of PCR, polymerase chain reaction, or the molecular assays that are used to detect the SARS-CoV virus and parts of the specific parts of the genome. What has happened, we can see here, looking at this report, and this is an analysis from the GISAID platform as well, show that there are changes in mutations that occur within the viruses can result in a mismatch with the primers that are used in these assays. Hence, your assays will become less sensitive and specific in actually detecting the SARS-CoV-2 virus. Therefore, ongoing assessment and evaluation of assays is also going to be important as we see the evolution of these variants. I showed this slide earlier. So in summary, when we take a closer look at the SARS-CoV-2 variants, and I have just summarized the key variants that are of public health concern at this point, we can see that SARS-CoV-2 has proven to be a genetically diverse virus that has now become endemic within humans. Structural and functional changes concomitant with spike protein mutations should be meticulously studied during therapy design and development. Identifying and tracking clades that become dominant in certain geographical regions may inform the development of effective vaccination, as certain antiviral drugs may not work against mutated forms of the virus or clades or of viruses that have developed resistance through genomic mutations. This includes improving sequencing capacity in national laboratories and national influenza centers. Some variants, such as the SARS-CoV-2 B117 lineage, have been associated with increased transmissibility. And whereas increased transmissibility may not directly relate to increased mortality, increased transmissibility will, as the pandemic evolves, relate to increased morbidity, and if you have your health systems being overwhelmed, it can also result in increased mortality. So maintaining mitigating procedures advised by national authorities such as WHO, CDC, PAHO continue to be important as this pandemic evolves. Both pharmaceutical and non-pharmaceutical measures are important. The manufacturing and equitable distribution of effective vaccines, along with mitigating procedures, will be critical in decreasing the morbidity and mortality associated with the COVID-19 pandemic. Thank you.
Thank you very much, Dr. Jackson Betty. We are really, we got a very deep picture of the variants, the issue of variants. It's a bit of a complex subject, but we actually we were able to get that insight into where we are, looking at what's happening not only in Jamaica, Caribbean, but across the world. And at the end, I think I'm trying to find some comfort in what Dr. Jackson Betty shared with us, that we have to still continue to work on she talked about the role of pharmaceutical and non-pharmaceutical approaches. And at the scientific level, the importance of the surveillance, and she spoke about the concept of genomic surveillance, which I suppose she might have answered my question. My question to her would have been, if in relation to our regular testing for the virus, as we get cases and people go to the labs and get tested, are we able to, with the presence of variant strains coming in the whole ecology of the virus, would we, without new testing, without new genetic testing in the labs, pick up these variants, or do we have to go look for it? And I think what I'm hearing from her is that we got to go look for them with the genomic surveillance, or else we will not be able to put our finger on it. So I think it's that has certainly been added knowledge to our understanding. The other thing she said, I would say at the end, is that the SARS-CoV-2 virus is now endemic among us. So it's now here. I mean, I don't know, Doc, if you want to elaborate on that. You're saying it is here with us. When we think of endemicity, we think of the regular ongoing occurrence of the virus in the population. And one of, I think it was Professor Figueroa before, said, we have to learn to live with COVID-19. Are we, Doc, are we at a point where we're saying, look, this is going to be here with us? And a lot of people ask that question to both laymen and health professionals. When will it go away? From the virology point of view, what are we looking at? Are we, after all is said and done, we're going to get vaccines and control the pandemic? Are we going to see SARS-CoV-2 remaining around with us in our populations? If you can say a little bit about that for us, please.
Thank you, Dean Paul, for that question. CDC and quite a number of international authorities believe that the virus will become endemic. And just as we were able to control polio, measles, yellow fever, and other infectious diseases, if we take the correct approach and attitude, scientific approach to the control of coronavirus, SARS-CoV-2, COVID-19, we should be able to take control of the pandemic and move forward.
Thanks. So what we're hearing really is that there's encouraging news that, I'll paraphrase what she just said. We did it for polio, we did it for measles, we did it for rubella, and our expanded immunization program back then made an impact. We still need to keep on top of those, by the way, and we need to continue to immunize our younger children and those unimmunized. But what I'm hearing our virologists telling us is that we can do it for COVID-19 and for SARS-CoV-2. And we're hearing that we'll hear later on about the vaccine. Prof. Celia Christie will talk about that, but we are saying that there is hope. From the biology of the virus and the virology and all the strains and variant strains, what we're hearing is that we can do this. We can get on top of it over time once we apply the science and the knowledge and the technology. So that's good news. Good to hear the words. Thank you very much, Dr. Jackson Betty, for your brilliant lecture. I mean, I think really this is a complex subject. I always tease and say it's amazing how we can study this little thing and have so much knowledge coming out of it. But we are blessed by having our scientists, our virologists, those who can bring this knowledge to us and this expertise. So let's thank Dr. Sandra Jackson Betty again for sharing with us. Thank you very much. Our next speaker is going to share with us the clinical features and outcomes of COVID-19. As we said at the start, we saw it back in March. We began to see this new condition. People say, boy, it looks like the flu, etc. We learned about the impact on the lungs. We had a lot of chat about what's happening to the lungs and we have come down, it's almost a year. And we really want to share with you what have we learned about the clinical features and outcomes. What does it really look like at this point in time? And our speaker is internist, intensivist, nephrologist, very distinguished, has studied at Montefiore Medical Center, they're well-renowned in New York, and the Johns Hopkins Hospital, also in Maryland. Her interests focus on sickle cell and nephropathy, but because as the COVID pandemic has taken on with the kind of skills that she brings to the table and the kind of expertise, she has been able to be on the very front line of managing COVID-19 patients in the hospital setting. And so I'm very, very pleased to bring to the podium our associate lecturer at the University of the West Indies, Dr. Laurie Ann Fisher, to speak to us on clinical features and outcomes of COVID-19. Let's welcome Dr. Laurie Ann Fisher.
Good morning, everyone. Thank you for having me present today on the clinical features and outcomes of COVID-19. We've learned a lot in the last year about although this is a novel disease, we've learned a lot through experience and some of the clinical features, and we're now learning some of the outcomes of COVID-19. So COVID-19 is caused by the novel severe respiratory syndrome coronavirus, SARS, COVID-2. It first emerged in December of 2019 after a cluster of patients were found to have pneumonia in Wuhan, China. SARS-CoV infection can cause a wide spectrum of clinical features. This ranges from asymptomatic disease to what you see in the picture on the screen, where you have a patient who is prone, he has multiple connecting tubes, multiple infusion pumps. There is the ventilator and also a dialysis machine in the background. He's getting continuous renal replacement therapy, and the physician or nurses are taking care of him. So the epidemiology. As of this week, there's 95 million cases globally, accounting for about 2 million deaths. In Jamaica, there are 14,000 cases with 326 deaths. Since March and January 18, there have been 444 admissions to the isolation wards for COVID-19. The diagram or graph to the left of your screen shows the distribution of hospitalizations and mortality in the US between March and January of this year. Additionally, with our university hospital data, these are the admissions, the weekly admission rates for COVID-19 between March 9 and January 4. We had a peak of cases in August and September of 2020, with cases slowly coming down, but actually rising again nidering again in January of this year. So a little bit of the pathogenesis, won't go into too much detail, but essentially, the COVID or the SARS coronavirus actually attaches through viral particles on your cell receptors. This leads to both, what's really important is that it causes an inflammatory state, which is both thrombotic and may cause the release of tumor necrosis factor alpha and many cytokines, leading to an inflammatory response. There may be the role of angiotensin system activation and also the role of the receptor in modulating this response. There is a clinical spectrum of disease, as I said before, so it ranges from asymptomatic disease to respiratory disease, which may be mild, moderate, or severe. Other manifestations include neurological manifestations, cardiovascular manifestations, and thrombotic manifestations. So, asymptomatic infection. So, one study looking at 3 large cohorts that identified cases through population-based testing, meaning that they just randomly tested participants regardless of clinical status, and they found that asymptomatic patients accounted for about 40 to 45% of SARS-CoV infections. Interestingly, viral transmission is still possible with asymptomatic infection, and the duration of this is unknown. Some papers cite about 14 days, but it's not very clear. I must point out, though, that this data was cross-sectional, so there's no longitudinal follow-up. So at the time of the testing, these persons were asymptomatic, but we don't know if later on they developed symptoms. And this is really important because this is a small case series from China in 24 patients who were contacts of COVID, confirmed COVID patients who were asymptomatic at the time, so they were confirmed COVID, and they just underwent CTs. 50% of them had typical ground glass opacities or patchy shadowing, and another 20% had atypical imaging abnormalities. Of note, none of the patients died. Only about 7% of the patients were admitted and later developed symptoms. So this is the largest case series from 72,314 cases from the Chinese Center of Disease Control. About 81% of patients had mild, so no pneumonia, mild disease, maybe just cough, a little bit of dyspnea, but no evidence of pneumonia. About 14% of persons had severe disease, so dyspnea, hypoxia, more than 50% lung involvement on imaging within 24 to 48 hours, and 5% had critical illness. So they had multi-organ failure, required mechanical ventilation, were in shock, or had acute renal failure. The overall case fatality rate was 2.3%, and no deaths were reported with those with mild disease. Most of the deaths were with patients with severe disease or critical illness. So as we know and has been propagated in newspapers everywhere, advanced age is a risk factor for severe illness. So what this graph highlights is that as age progresses, your mortality increases, and this actually highlights this very well. This is data from the same Chinese study. Comorbidities, so diabetes, in particular impaired renal function, hypertension, obesity, smoking, cancers, in particular hematological cancers, and smoking were risk factors. And this is the next graph shows, and I'm sure it doesn't project very well, but I think you can appreciate an image more than you can appreciate words on a slide. So what you see here is data from the UK, which looked at mortality or factors affecting mortality in patients with COVID-19 infection, the first thing at the top is age. So as you see, age is stratified by 10 to 15-year bands. The hazard ratio or the risk of infection was highest. So the one with the most extreme, that's a hazard ratio about 5, is the over 80 group. Right, but things like chronic kidney disease, hypertension, or diabetes was clinically significant, and cancers were higher risk. And you can see along the scatter plot that those are higher risk. So clinical features. So again, this is from data from the CDC. So in 50%, the most common clinical manifestation is cough. That's present in 50% of patients, followed by fever, which may be subjective, or true temperature, more than 100.4 degrees. The myalgia, headache, dyspnea, sore throat, diarrhea, nausea, and vomiting were amongst top clinical features. But the classic feature which you all hear is anosmia, loss of taste, loss of smell, also a common manifestation. Rhinorrhea, abdominal pain were also manifestations. So other kind of non-specific presentations, conjunctivitis has been described. Non-specific features are common in older people. So patients over 80 may present with delirium, like just a general health decline and unexplained fatigue, falls. And additionally, for dermatological manifestations has been characterized and range from maculopapular, urticarial, vesicular eruptions, and livedo reticularis. And I have kind of those pictures showing the distribution. So here is the picture to your right. It's just acral kind of dermatitis, dactylitis, and maculopapular eruptions. So the most common thing, respiratory failure. So ARDS, acute respiratory distress syndrome, is a major complication. And it can manifest shortly after the onset of dyspnea, and usually maximal after 3 to 10 days after symptom onset. In a study of 138 patients, ARDS developed in 1 in 5 persons, with a median of 8 days after the onset of symptoms. And mechanical ventilation was implemented in 12% of persons. I should say invasive mechanical ventilation, and the rest were usually high flow oxygen systems or non-invasive mechanical ventilation, i.e. BiPAP or CPAP. In large studies from the US, 12 to 25% of hospitalized patients required mechanical ventilation. Other complications would be cardiovascular manifestations, and they've included arrhythmias, acute cardiac injury. In a case series from Washington, of 21 severely ill patients, a third of them, 33%, had evidence by echocardiography of cardiomyopathy. In China, the same study that I quoted to you before, there were the incidence of arrhythmias was about 17%, in acute cardiac injury was 7%, and shock was in 9% of persons. So thrombotic complications can occur. PE, there's an increased incidence of pulmonary embolism. It's both venous and arterial. So pulmonary embolism, DVT, acute stroke, which can be embolic arterial, and venous thrombosis. So the CT scan to the left is an actual patient who was presented to the hospital with headaches and blurred vision, actually at UWI. Had a remote 2-week prior history of fever. At the time was completely asymptomatic, found to have hair, which is a dural sinus thrombosis, and COVID testing revealed very high antibody titers. So this occurred post-COVID infection in a relatively asymptomatic case. It's really important that the thrombotic complications may occur in younger people, and they may have had mild or very minimal symptoms. Encephalopathy is a common complication of COVID-19, especially amongst critically ill patients, and it's present in up to a third of patients. Stroke, movement disorders, motor and sensory deficits, ataxia, and seizures may occur, but less frequently. The most common thing is an encephalopathy. Guillain-Barré syndrome has been described, and it can occur 5 to 10 days after initial symptoms. So the COVID inflammatory response, so the so-called cytokine storm, is essentially an exuberant inflammatory response, and it's characterized by fever, elevated elevated inflammatory markers, increased pro-inflammatory cytokines like interleukin-6 and tumor necrosis factor alpha, and is associated with critical and almost nearly fatal illnesses. In children, a multisystem inflammatory syndrome with clinical features similar to those of Kawasaki and toxic shock has also been described, particularly from reports out of the UK and also in China and in the US. So lab findings. So lymphopenia, elevated AST, LDH levels, and any markers of inflammation, because again, this causes an inflammatory response. So ferritin, C-reactive protein, ESR. Lymphopenia is very common and associated with mortality. So in a study from New York, 90% of those with a lymphocyte count of less than 1,500 essentially had, worse outcomes. I think they had more mechanical ventilation. Also, they were more likely to die. I'm going to show you a slide very soon of lab findings associated with death. Higher D-dimer levels and more lymphopenia have been associated with critical illness or mortality. Thrombocytopenia and elevated troponin and CPK likely representing cardiac injury. And again, in my area, acute kidney injury is associated with significantly worsening outcomes and death. So just to let you know about radiological manifestations, on chest X-ray, there may be no findings, up to 20%. The most common findings on X-ray may be consolidation, ground glass, bilateral, which are usually bilateral, peripheral, and lower lung. The lung involvement increases over the course of illness, and it peaks at about 10 to 12 days. There has been case reports of spontaneous pneumothorax, although it's uncommon. The CT chest is more sensitive than X-ray. What's really important is no finding can completely rule in or rule out CT on COVID-19 on imaging. What the American College of Radiologists recommend is don't use it for screening. So don't use CT scanning for screening. You may reserve it for hospitalized patients when needed to guide management and also for prognosis, right? But we don't, the way how we've been recording it in additionally at UA is typical, indeterminate, or atypical as or kind of response as the language for radiological manifestations. So what's interesting is that there was a meta-analysis of over 2,700 patients, and the most common finding in 83% of persons was ground glass opacities. 58% had ground glass opacities with consolidation, 50% had pleural thickening or interseptal thickening, and 46% had air bronchograms. So again, the same recurring theme of consolidation and ground glass appearance. The CT abnormalities in COVID are often bilateral, have a peripheral distribution, and involve the lower lobes. Now that's a CT scan actually. This is from, again, the study from China with a patient who actually required extracorporeal membrane oxygenation. It's early in the top 3 slides, so early in the course of his illness, so probably day 1, day 2, and then this is, I think, day 19. The bottom one is at day 19 of his infection, where his imaging has improved. So these are the lab findings associated with survival. So on the top, you have kind of the white count. So as you white count, or your lymphocytes in particular drop, you actually have more mortality. In addition, if your neutrophils rise, right? So neutrophilia is associated with worse outcomes. In the bottom, you can't forget the kidneys. So as the kidney function declines, you are less likely to survive, right? So the bone and creatinine rising later on is associated with worse survival. Elevated D-dimers, again, these are all markers of an inflammatory response. And I like this slide because it's like a nice summary slide of all the things I just discussed. So, all the systems that can be involved in COVID infection. So thrombotic risk, dermatological, respiratory, cardiovascular, hepatic, which I didn't mention, but it can get elevated AST, ALT, gastrointestinal, so nausea, vomiting, and renal, acute kidney injury, dialysis requirements. They've also had case reports of glomerulonephritis or post-infectious glomerulonephritis resulting in hematuria and proteinuria after COVID infection, in addition to a host of neurological manifestations. Outcomes. So we don't really think to talk about long-term outcomes in patients with COVID disease in general. So there's actually a syndrome called long COVID or post-COVID syndrome, and it's been designated as by the National Healthcare or NICE, National Institute for Healthcare and Excellence, as signs of symptoms that develop following an infection consistent with COVID, which continue for more than 12 weeks and are not explained by alternative diagnoses. So it's quite similar to post-ICU syndrome, which we kind of see quite often in our patients. So those patients who've been ventilated, who've been, had acute respiratory distress syndrome, they develop a host of symptomatology after ICU discharge, including neurological and neuropsychiatric manifestations, pulmonary manifestations, including dyspnea, and rehabilitation and pain in particular. This was actually a study published of 47,000 patients, mean age of about 65 years in hospital from UK-based data. And these were some that were hospitalized and some who were not hospitalized. They were all discharged alive on the 30th of August. And they matched the controls with the same kind of clinical characteristics. What's really concerning about this paper is that even after a follow-up time of 140 days for the COVID-19 patients, 766 admissions, readmissions, and 320 deaths per 1,000 persons were observed in COVID cases, and that's very concerning. And the last slide is even concerning, was that there was the rates of respiratory, diabetes, and cardiovascular events were significantly increased in COVID cases. This is even 3 months after their initial diagnosis. And this is an interesting paper that I came across in terms of post-COVID ICU syndrome. So this is 2,100 persons as part of a Facebook group for coronavirus patients with persistent complaints in Netherlands and Belgium. Only 12 of these people were hospitalized. The most common symptoms that persisted, even up to 3 months after onset, were fatigue and dyspnea. And that's present in a significant amount, 71% and 87%, even of those 2,000 persons continued to have dyspnea up to 3 months after their diagnosis. And again, this is relatively asymptomatic disease because most of these patients were not admitted. So in summary, COVID-19 causes a range of clinical manifestations from asymptomatic disease to severe multi-organ failure. Neurological, cardiovascular, thrombotic manifestations can occur and may be unrelated to the severity of illness, which is an important note. COVID-19 may be associated with adverse short-term and long-term outcomes, as we say. And again, just for a push for research, regional, cross-sectional, and longitudinal studies are needed to quantify high-risk groups, long-term effects, and guide policy on resource allocation. And I think that's the end. Thank you very much.
Thank you very much, Dr. Fisher. I want to thank Dr. Fisher for that talk. And I have, very, very, very enlightening information. We had a picture of the clinical features, and this has given us a very detailed look. We looked at the laboratory, the radiology, etc. But we're hearing some new information, almost hot off the press, so to speak. Speaking to the post-COVID-19 outcomes and the syndromes that we're seeing. I have a question for Dr. Fisher. We talk about we knew in our prior teleconferences, COVID-19 having an impact on persons with, the hypertension, diabetes, those at high risk of those conditions. The question with the paper that you referred to, post-COVID, are we seeing the incidence of conditions like diabetes increasing, or are we seeing a worsening of what was already there? Are we seeing new disease, or is it a worsening? You can.
Right. So I actually think that, at least based on what I read, that it's probably going to be a combination of both. So remember that a lot of the treatment for, for COVID-19 is actually steroid-based therapy. So it may have unmasked, especially with the diabetes and, elevated salt and water retention. Additionally, does the cost of the admission, does admissions itself. So like there is secondary bacterial infection, there is a lot of other things that are long-term, and I didn't even go into the long-term pulmonary manifestations, which we're not quite aware of. There is an increased risk of kidney disease, and certainly when patients, and I suspect that may be also part of it, so patients who develop acute kidney injury that require dialysis long-term will develop hypertension and stuff related to that. So I do think it may be one, like, unmasking prior chronic illnesses, but also some of the interventions and some of the direct consequences of COVID itself may be leading to this infection, these chronic illnesses that we're seeing.
Thank you very much. Certainly, the reflection, a somber reflection in terms of the burden, the disease burden that this virus has brought to us. And our earlier speaker, Professor Figueroa, spoke about almost learning to live with COVID in the foreseeable future, and the need for us to still obey. If you remember in his talk, as he talked about vaccines, he still says we need to look at the non-pharmacological approaches to prevention, still wearing our masks, social distancing, sanitizing, etc., hand washing, all an important part of your enhanced New Year resolution for COVID-19, which is what this conference is speaking to. So I want to, if you have just joined us, I want to welcome you again to our COVID-19 Making New Year Resolution Conference. I want to say you've just heard a an excellent talk from Dr. Lorian Fisher. Please put your questions in the chat. We will answer them. We are here and we'll be monitoring your questions and your comments. We are very grateful for your feedback, and thank you for joining us on this conference. Thanks again, Dr. Lorian Fisher. Excellent talk. Thanks for your contribution to this conference. Thank you. As we continue on the COVID-19 teleconference, we are going to look at the care of special populations during the COVID-19 pandemic. We have our speaker for this presentation is Professor Denise Eldemire-Shearer. Professor Shearer is Professor of Gerontology and head of the Mona Aging and Wellness Center. And that's a good context to put the talk, because we know that with respect to COVID-19, we have challenges in terms of vulnerability of the older, our seniors, and also those with comorbid conditions. So again, over time, we want to get an update on this. How have the interventions worked in protecting these special populations? What strategies do we need to adopt differently, enhance, continue? We're going to hear it all from Prof. Eldemire-Shearer as she shares with us the experience over the year, or over the period since the pandemic, on managing and caring for special populations. Let us welcome Professor Denise Eldemire-Shearer.
Good morning, and thank you very much, Dean. And thank you for including this very important topic in your workshop. I'm going to be looking at managing and caring for special populations with an emphasis on older people. During the talk, I'm going to look at where we are in the pandemic now as it applies to older people. Where relevant, I will mention other special populations. What was done to reduce the impact on older persons? What is that impact, and what we can expect going forward? One of the things that at the start of this conversation that we need to recognize is that older persons are a very diverse group. When we talk about other age groups such as children, there's a lot of similarities. That's not so amongst this population, and we need to recognize that. So whereas we will talk about older people, even within the various bands of older people, age bands, there are differences. So where are we now compared to last April when we did the first seminar? In March of last year, older persons were identified as a vulnerable group and targeted for intervention. The information for this came out of the situation in China. It was later confirmed by WHO and by CDC, in that older people the case fatality rate was higher, and there were a number of risk factors for older people where they got more disease and the disease was more severe. A review of the case fatalities and of the morbidities suggests that this was in fact correct, not just for the other countries, but for Jamaica. So in March, when they were identified, a number of measures were put in place, targeting older people as a special group. When we look at the case fatality in older persons for Jamaica, we see that this is in fact so. We have an overall fatality rate of somewhere around 2, and we have figures thanks to the Ministry of Health for April last year, October, and as recently as last week. So the overall fatality has not changed, yet we have seen movements within the older age groups which start off as higher. In last year, when we were under 100 cases, we had a case fatality of 3.6 among 60 to 69, going up to 14.8% among 80 and over. 80 and over, even without COVID, in considering the characteristics of the older population, has always been identified as having more frailty and being more at risk of the impact of disease. So this finding is not surprising. We see that it has continued to move up as the number of cases have increased. So, for example, 70 to 79 went from 8 to 12 to now 12.7. 80 has gone from 14.8 to 17.4 to 18. And in the last set of statistics, the 90 year and over was calculated, and it was at 32.6%. So when you look at the older people, 72% of the deaths that we have seen in Jamaica, of 322 in the slightly over 14,000 cases, 72% are in older people, and therefore justifies all of the attention on considering them as a special group. How are we doing with respect to the rest of the world? We're actually doing fairly well, and I have chosen 2 countries to look at because a lot is said about availability of healthcare services and the type of healthcare services, a lot of discussions around ventilators. And as you can see from these statistics from Italy, Spain, and China, we are not doing badly because we are pretty much the same. In the US, 8 out of 10 deaths are now in the over 65s. And we are not quite there. So we are holding our own with regard to the impact of COVID on older people. So the age distribution you can see here is and you see the impact of the case fatality there, and you see the number of deaths. But given what it could have been, with 70% of older people having at least 1 chronic disease, and 42% having at least 2 chronic diseases, 50% of older people are overweight, and this data is from the Mona Aging and Wellness Center's national survey. It could have been far worse if there was no intervention. The interventions have reduced the number of cases, and despite being a vulnerable group, the group infection is not higher. I've said low. Really, it's not higher than as would have been expected, and as we are seeing, for example, in the US. But we are seeing the same 15% of cases are over 60, which is the population. We would have expected it to be somewhere between 20 and 25%. So we see and among the older people themselves, the 60 to 69 is accounting for 50% of the over 60 cases. You will remember that the stay-at-home order is on 70 and over. Therefore, the 60 to 69 are not being as restricted. They are to work from home, and they are guided by the public health regulations of masking, etc. So we see that the stay-at-home is having its impact. And this slide gives you the age distribution, which supports the point I'm making, that of the almost 14,000 cases, the older people are not in excess. So although the deaths are in excess, the actual number of cases are not in excess, suggesting the measures are avoiding infection among this particular age group. And this slide just captures graphically the fact that it's that the 60 to 69 age group that has most illness. So what is the impact of the intervention? And I think we all remember these interventions. The stay-at-home order, which started at 75 and was later reduced to 70 based on information, drawing on international studies as well as local. So the Mona Aging and Wellness Center have done 2 studies, and we're currently doing a follow-up study. And the questions were driven by the many comments, media, and from healthcare workers that we are not taking COVID seriously enough. We see it. We see the lack of masks out on the street. People are about their business. We hear about the parties. Now, 71% of older people were concerned about COVID, and we had a sample of 600. 26 were very concerned. Only 3% were not concerned. So this differs significantly to the regular population. 50% thought that it meant government, the interventions meant government actually cared about older persons. They were not seeing it as an imposition. This is significant because since the targeting of older people started across the world, aged care advocates have said targeting older people is ageist, is against their rights, freedom of movement. And it has led to an international discussion, the difference between individual aging, population aging. And it has been very interesting watching the literature, and the various organizations have come around in their thinking. By December, they were saying, well, governments do have a responsibility to population measures, and therefore there are some merits in staying at home. 92% of the Jamaican 70 and over were staying home. In a small study in December, most of them, persons that were called back, said they had only left home once or twice. This does have some concerns, which I will mention, because the stay-at-home does say you can leave once a day for essentials of life. Older people's interpretation of essentials of life has been quite interesting, and going to the doctor and following up on healthcare is not seen as an essential. Now, we have to view the considerations for this population, particularly healthcare workers, in that 20% of older people live alone. Therefore, when the stay-at-home was put in place, the suggestion was family, neighbors, and who lived with you could therefore get you the food, get you your prescriptions. We have another 24% with spouses only, so they also had to stay at home as they were in the same elderly age group. So there are issues with getting supplies, food and medications. 24% report less physical contact and affection, some intentionally. Now, we know that self-worth, self-actualization, integrity, and those social, psychological parameters rely very, very heavily on love and affection. People who are not going to work rely on each other and on their family. And this is an area that has been severely restricted by the interventions. 31% reported a reduced ability to support themselves. 60% of them took public transportation and were able to say, but we were told not to take taxis or public transportation. Hence, that's why we're not going to the doctor. Healthcare has been impacted by the restrictions or interventions. Let's not call them restrictions because they're for our good. 60% had not sought healthcare in the 6 months since the interventions. Missed follow-up appointments, missed eye and dental care, and 11% actually missed hospital appointments. But as with all things, there is always a positive. The hospital and primary care statistics are showing far less flu and pneumonia, which are normally seen in December, far less among older people. And the deaths due to pneumonia, often seen in December among older people, are not there this year, probably because they're not being exposed. Persons with dementia had different issues. Remember that we have a 6% prevalence rate of dementia, and we have a 30% rate of mild cognitive impairment. There was great fear and anxiety about masks. One lady who I saw in my office wanted to know what she had, that she had to be kept away from people. And she got quite hysterical. In fact, we ended up having to take off the mask and do the social distancing because she had gotten so anxious. They are missing their regular caregivers because of transportation problems, so they do not have the normal caregiver. And we know that persons with dementia like routine, and they don't like new people. They can't adjust to new people. Some of the caregivers could not come because of the transportation issues, and some of the families took the messages literally and stopped the caregivers from coming. Nursing homes were not admitting new patients, and this was a problem because the normal or the commonly seen problems of older people, the strokes, the diabetes, the amputations, did not go away. And in fact, there was a case I had where the wife, who was considerably younger, had to go abroad for treatment. She was in the middle of cancer treatment and had to do her follow-up. And there was a lot of difficulty getting the 90-odd-year-old spouse in somewhere to stay. He couldn't be left at home alone. The nursing homes are reporting more bedridden. They report that they rely heavily on visitors, family, to walk people and to stimulate people when they visit. All of that stopped. And families began noticing mental issues and having assessments done. Now, the question here, and we will have to study it, is it that families were paying more attention for those that were around their older people, or is it that the social isolation and lack of social stimulation caused memory issues? Again, there is a positive. Unlike the US and New York and California, where we're hearing nonstop about deaths in nursing homes, both the state infirmaries and the private nursing homes have managed well. We only had one situation, the Golden Age home, which had 81 cases in a cluster, but they managed to restrict it to the cluster, so the other 7 clusters were not affected. And what was particularly rewarding to those of us looking after these situations, there was in fact only 1 death among the 84 persons that were affected. So that shouldn't be no deaths. It should be 1 death from persons in homes. We have not heard of any deaths from private nursing homes. So clearly we have lessons for others. Clearly the caregivers in homes and the measures put in place at the state homes and at the private homes, which were pretty rigorous, the sanitization, the masking, have worked. But social isolation does have its issues, loneliness and fear being the biggest ones. 34% in this study, and there are several cases now, we've done several case studies, that the fear in particular. In fact, last week during a regular family medicine lecture, after we had done what the resident had done and talked about hypertension, when the gentleman was asked, do you have any questions? He only wanted to talk about COVID. So there is a fear, there is an anxiety. I've been asked in my practice, when are you going to test me for COVID? And these are people who have stayed at home. With homeschooling, there is now less family contact, and there is the intergenerational, not war, but conflict of need, because persons who would be dealing with older people while children went to school now have to deal with the younger people. So that has become an issue. And of course, the stay-at-home means less physical activity, sitting down in a chair, more sedentary lifestyle with muscle mass loss, falls, and such. The stay-at-home has exposed the drawbacks of not being digitally savvy among our older people, and the online banking in particular has been an issue. They simply cannot measure it. There was a case last week where an older person was fighting with an ATM machine and simply handed both the bank card and the PIN number to the person next in line and said, "Please help me." So there are risks associated with the stay-at-home, and we need to be aware of them. They have resisted telemedicine. They like to be touched, they like to be examined, and they don't think a phone call from their doctor is a visit. Yes, they appreciate the call from the doctor to check up on them, but that's not an examination. So what then are our post-pandemic expectations? Our post-pandemic is that the resilience, not residence, the resilience of older people will help them. They will be able to come to grips with what has happened, just as they have with hurricanes and other major problems, and they will be able to bounce back. The problem here is, are they going to be strong enough? Because the physical inactivity that I mentioned, I have several patients now that were up and about, that were doing walking, that now are using walkers. Because for 10 months, remember the pandemic is now 10 months old, older people need to move around, they need to use their muscles. If you don't use it, you're going to lose it. And we find that there's a lot of this muscle mass weakness and some cases of sarcopenia because diet has been impacted by the not having as much money and by the fact that not as much fruit and vegetables are available, given that people cannot go and come from the country the way they used to. We're going to have more problems with chronic disease. I don't think that's up for question. We are getting reports, and we're seeing the statistics coming out of hospitals that know that the newness of the pandemic has worn off and people are coming to hospital for serious illness. We're seeing the strokes, etc. But you have to take into consideration, when we asked the older people, most had only left the house once or twice. And if given that follow-up visits for prescriptions are usually every 3 months, we can see that a number of them are running out of medications. Some are being told by their doctors and by health centers, simply pick up a prescription. That means that the sugar levels are not being checked, the blood pressure is not being checked, and they're simply repeating. Some are not filling the prescriptions. So the issue around this, the complications of chronic disease, I suggest we are going to see in 2021. The reduction in mobility, the increase in geriatric syndromes. And of course, there is the risk of post-traumatic stress disorder, which the fear, the anxiety, the loneliness can bring on. Also, many of our older people, 50% of them from our national survey, the families are abroad. And therefore, there is the fear and the stress of what's happening to the family. One lady that I know had to come home because she had gone abroad for educational purposes, but the hysteria of her mother every week that she was going to die in New York because of what was happening, she came back home. The other thing, too, is that with the laying off of people abroad, money is not coming. The money's not coming like it used to. Yes, they'll send the occasional check, but the remittances are definitely down, and 78% of older people rely on family for support. They don't have adequate pensions, And the families themselves are under stress, not just abroad. We've seen many loss of jobs here. So there are issues that we are going to have to face in 2021. And I suspect that we are going to see some of the older people, and certainly the families with older people that were just above the poverty line, going below. We have to remember that many of our older people are grandparents, and many of them have children, also a special population. Whereas before we said that we didn't have to worry about the children, the new, and thanks to Professor Christie for this slide, who insisted that I include something about children, very appropriately because of the role of older people with grandchildren. So they have to know about it and they have to respect it. The new variants do infect children, 70% more. Now, 70% of a low rate is still a low rate, but you have to recognize they are going to infect them. So with some of the back to school, are they going to bring it home? We have heard about the multisystemic inflammatory syndrome in children. It's very rare, but it does have significant morbidity and mortality. And I'm not sure that we have reported it in Jamaica, but it has been reported abroad. And we have a case here that she has put in for us. Just to remind us, there was a 12-year-old that was admitted with COVID-19 with fever, rash, arms and legs, joint pain, chills, extremity swelling and erythema. As we talk about the children, school reopening, implementing public health guidelines to reduce transmission, masks, physical distancing is all important. We also have to remember with regard to older people that there are the long haulers, as they're being called. And there are 5 cases that were of persons, 2 of which were elderly, so 40%, that were admitted to university with hospital with severe respiratory problems. They had negative PCRs, so no current COVID, but they were positive for the antigen, so that means they had COVID. So these are the long haulers that we're hearing about. We have certainly seen those here. And we have had 1 case reported, and I stress reported because with the stay at home, we don't know how many others have not come forward, where there was severe brain damage after a long ICU stay and on a ventilator, and now with dementia. So this brings us to the end of looking at older people as our special population. And in summary, the measures to prevent infection and to protect our older people are necessary, and they have worked. The evidence is that when older people are exposed, they do get the infection and they are much more at risk of severe infection than other populations. Thank you.
I want to thank Professor Denise Eldemire-Shearer for her really excellent talk. As always, Prof talks from the heart and the science. She brings the science and the heart together and connects with us. We can hear from her experience and description that the stay-at-home request that was made and the implementation of the stay-at-home for our seniors has made a difference in terms of the impact on the pandemic. But at the same time, she raised the issues of the impact on their social and mental well-being, and we need to address all of this. So we're really thankful for giving us this update, Prof. We look forward to playing our role as a community in supporting and caring for our seniors and those with comorbid conditions. Remember, wearing my mask will help prevent the spread to someone else. Might be a senior, might be somebody with comorbid conditions. So let's do all together, as Prof has encouraged us to do in her talk. Thank you very much, Prof. Shearer. I'd like to encourage all of our attendees at our teleconference today to continue to put their questions and comments in the chat. We will respond as we go forward at our conference. Now we're going to look at treatment for COVID-19. We have had a very interesting journey over time with the treatment options, and at some point some folks were saying there really isn't much treatment, but we have continued to look at modalities, in addition to the core supportive treatment, to look at drugs and new options, and trials have taken place, are taking place. And so we want to ask a question as we look at our New Year resolution and new knowledge. Are there now tried and proven treatments for COVID-19? It's a big question, very interesting question. And so we want someone who has the first-hand experience with treating COVID-19 patients, who has looked at it both in terms of their own experience, but also who has looked at the science and the literature and the knowledge to speak to us. And there's no better person than Dr. Kelvin Metalor. Dr. Kelvin Metalor is an intensivist. He is head of the ICU unit of the ICU here at the University Hospital of the West Indies. And he's a lecturer in the Department of Surgery, Radiology, Anesthetics, and Intensive Care. He has spoken to us before. He gave a lovely talk at one of our conferences where he had the analogy of the treatment in relation to war, a fight, frontline and different types of approaches to fighting the battle. Well, let's hear what he has added to the armamentarium today as he shares with us on the current, new, emerging, established therapies for COVID-19. Let's welcome Dr. Kelvin Metalor.
Good afternoon, everyone. Welcome again to another session of the University of the West Indies COVID conference series. Let me use this opportunity to thank Dean Dr. Tomlin Paul for the invitation to present at this conference again, and thank Professor Christie, who is the chief organizer of this conference series. So this afternoon, we'll be looking at COVID-19 here in Jamaica, especially from a critical care point of view. And we will be looking at what are the current tried and proven therapies, if there are any, for that matter. So let me just begin with the basic introduction, which I'm pretty sure that most of us are already familiar with. That this particular virus, this novel virus, emerged in December of 2019. At least was first reported in December of 2019 from Wuhan, China. And of course, immediately became a public health emergency of international concern. And we had our first case of coronavirus disease in Jamaica confirmed in March 2020. Over the last 1 year or thereabout, there has been quite a plethora of events. In that 1 year period, or just less than a year period, it has become a pandemic with unprecedented number of cases, over 90 million cases, I believe, or thereabout, and an unprecedented number of publications and worldwide collaboration to address this international threat. Now, the bedrock of any clinical management, of course, is early and effective treatment, early identification and testing for persons who may be infected, and of course, early intervention. And these are some of the things that we will quickly look at. Prevention of disease progression to more serious illnesses. And of course, there are a number of novel treatments that have been available over that period of time. What I'll be attempting to do this afternoon is to look at if there are any tried and proven therapies, and of course, attempting to separate the wheat from the chaff. Jamaica has recorded over 14,000 cases of SARS corona positive COVID-19 cases, and over 300 deaths. Several approaches to the management have been proposed, and there are public health measures that are aimed to prevent transmission, which have been put in place, and infection prevention and control measures, clinical management, and supportive care. Now, of course, we know that where there is no vision, the people perish. So a national approach is needed to coordinate all activities and efforts. And there is one here in Jamaica as well. And that national approach provides a clear plan with detailed command structure and flow, a national task force consisting of members from several areas. And the aim is public health education, information, strategic planning, and implementation of managing these conditions. Just to speak a little bit on that, through the government of Jamaica, through the Ministry of Health and Wellness, established the Emergency Operating Center, the EOC, which is the national task force that is charged with the responsibility of nationally leading the charge and daily management of COVID-19 nationwide. It's comprised of representatives from all the major areas of the health sectors, including the university hospital, and chaired by the chief medical officer or a designee of the CMO. And in addition to that, the CMO established the clinical working group, which is actually a clinical group that is made up of specialists from several clinical fields that had a mandate of providing clinical updates and guidance and advising the CMO on clinical matters regarding COVID-19. Right. So that's actually just a brief summary of what happens, or the terms of reference for the clinical working group. Now, the government of Jamaica, via the Ministry of Health, has made several responses to COVID-19 over the year. There's been a lot of things have happened. There's been an island-wide curfew almost daily. Once the island reached a particular number, mandatory wearing of masks in public places. At one time there was closure of the country's airports and seaports to incoming travelers. They've been reopened since then. Closure of all the business processing outsourcing when there was a major outbreak in the BPO in April of 2020. A stay-at-home order for persons over 70 years and older, which is still in place. Having non-essential employees work from home, limiting public gatherings, closure of schools, etc. Now, in order for us to navigate this complex journey, we basically need to have a clear understanding of the time course and pathogenesis of COVID-19. The clinicians need accurate evidence regarding effective medical treatment, and there have been several publications over the year. And of course, there's been major repurposing of drugs, experimental treatment, etc. There's just been a lot of activity in the last 1 year. We all know that the therapeutic and pharmacological management of severe COVID-19 should be guided by scientific discovery and clinical data generated by the large number of people rapidly infected. And there has been international collaboration, pharmacotherapeutics guided by the understanding of the stages and phases of the disease, namely the viral kinetics, immunopathogenesis, and drugs and interventions are most effective when appropriately selected and timed. Now, this particular diagram basically just shows us what happens at risk levels with COVID-19. There you have SARS-CoV-2 infection to the hosts and all the other factors that are involved in the development of the disease condition, the risk factors, pre-existing conditions, and of course, host and genetic variation that are involved. Under the risk factor, we see the male minorities, population density, poor sanitary conditions, pre-existing conditions in Jamaica here, particularly obesity, hypertension, and diabetes form the trifecta that put patients at significant risk for developing severe COVID-19 disease. And this particular diagram, which we again will take a look at later, just look at the time kinetics of this particular virus, starting from incubation, the period of time of viral replication, the immune response, both the delayed innate immunity, as well as the immune dysregulation that happened usually anything from about 10 to 14 days, as much as 28 days after infection with the virus, and the various presentation that persons undergo. As I said earlier, there have been over 14,000 cases of COVID-19 reported in Jamaica as of January 20, 2021. Over 300 deaths, leading cause of death being acute hypoxemic failure. And this is usually complicated by all the various comorbidities. Almost all cases, we could say over 90% of cases that have died have been persons who have all different sorts of comorbidities. The leading comorbidities being hypertension, diabetes, cardiovascular disease, neurological disease, chronic kidney diseases, and obesity. These are the leading causes. And these will impact on when we look at our tried and proven therapies to see how, to see actually what works with us and what does not work. About 1/3 of the recorded cases of death in COVID-19 have happened in critical care facility, about 1/3 in other areas of the hospital, and about 1/3 outside of the hospital. These are important when we look at our proven interventions and therapeutics. Very often, it's actually quite tempting to think about tried and proven therapeutics, just looking at it from a pharmacotherapeutic point of view. That's actually quite a myopic way of looking at this condition, because in terms of interventions and therapeutics, we should go much broader than that, because there are many things that come to interplay that lead to a favorable outcome. And hopefully we can just briefly look at that in this very short presentation. So like I said, our aim is to separate the wheat from the chaff. So let's look at the wheat. Supplemental oxygen in hypoxic patients. Severe illness in COVID-19 typically occurs approximately 1 week after the onset of symptoms, and the commonest presentation usually is dyspnea, difficulty with breathing, which is usually often accompanied by hypoxemia. And sometimes these persons may actually they may not look hypoxemic, or they may not be very dyspneic. They may have quite significant all-called hypoxemia, and which has been seen quite and reported very frequently in COVID-19 conditions. Patients with severe diseases typically require supplemental oxygen and should be monitored closely for worsening respiratory status, because some patients may progress to acute respiratory distress syndrome, or ARDS. Now, the optimal oxygen saturation in adults with COVID-19 is uncertain. However, we should target an SpO2 of at least 94%. Within at least 92 to 96% seems logical, and anything less than that, certainly here in Jamaica, we're just beginning to look at it from 94. We used to think about it from 92, but the clinical working group revised that particular guideline and increased it to 94, and there are several reasons why that has been done. Acute hypoxemic respiratory failure is the leading cause of death in COVID-19, and in adults with COVID-19 and acute hypoxic respiratory failure, conventional oxygen therapy may be insufficient to meet the oxygen need of the patient. So other options need to be brought into play, such as the high flow nasal cannula, non-invasive ventilation or intubation, and invasive mechanical ventilation, or even extracorporeal membrane oxygenation. This is particularly important. The number one tried and proven therapy is oxygen. And so being able to deliver oxygen to patients as quickly as possible when they need it is critical. Earlier on in the pandemic, there was a lot of talk about ventilators. We actually know now it is really oxygenation. Ventilatory failure comes pretty late, it's down the line. Oxygenation, early oxygenation. Again, one of the things I would like to highlight in this particular meeting is the fact that where in very earlier on in the pandemic, persons used to talk about a happy hypoxic or happy hypoxemic patient. There is nothing like happy hypoxemic patient. What you have is a slow death. Somebody who is dying slowly until they just fall off the cliff. So we should not tolerate hypoxia of any kind. We should be aggressive about treating hypoxia. We should have a detailed plan on how to manage patients that present in the hospital with hypoxia. And we should be also aggressive about detecting hypoxia in patients and responding to it. This is by far the biggest and the most important delivery, the most important drug that we can deliver to a patient who has COVID-19, especially COVID pneumonia, is oxygen. In light of that, I want to talk about the use of the meters, what are known as the thermometers and the pulse oximeter. In symptomatic patients, monitoring with home pulse oximetry is recommended. And so what I would want to share today is that I believe every household in Jamaica should have a home pulse oximeter. Everyone should have one at home where you are able to check what your percentage oxygen saturation is. And persons should be taught how to use a simple home oximeter. Ambulatory desaturation less than 94% should prompt hospital admission, and persons should be taught that. When you analyze, and we looked at some of the some of our data here at the University Hospital, when you analyze the cause of death in persons who have died from COVID-19, you would realize that quite a number of persons either present to the hospital late, or at the time of presentation, they are very hypoxic, and they probably have been hypoxic for a significant period of time at home. And so at the time of presentation in the hospital, they have multi-organ dysfunction and failure. And so you may have persons who already have comorbid conditions such as hypertension or diabetes, who already have some degree of renal impairment, now having hypoxia or hypoxemia on top of all of that. And so very quickly they go into multi-organ dysfunction. And by the time they present in the hospital, they are pretty, they are very, very ill. And so, and some of them do not make it. So we cannot overemphasize the need for self-monitoring for oxygenation, and to ensure that persons are taught how to monitor for oxygenation if they are going to be managing any form of COVID-19, no matter how mild we think it is. The limitations of peripheral saturation monitors should also be considered, especially when we're using that as a means for triaging. Just a quick look at this particular publication, which was carried also in the New England Journal of Medicine Journal Watch. They looked at pulse oximetry in outpatients with COVID-19. 77 outpatients with SARS-CoV-2 positive in a single emergency room unit were discharged home and given pulse oximeter. These were patients who were considered to have mild form of COVID-19. And this is common because when you triage patients, you basically cannot admit everybody, all right? And we know that over 85% or thereabout of patients who would present with COVID-19 will have the mild form of it. And so they did a particular study in one particular unit, and this has been replicated in a number of other units worldwide. So they sent these patients home, but they gave them pulse oximeters to monitor their saturation 3 times each day, and to return to the emergency department if the oxygen saturation was less than 92%. 28 patients, that 36 of them, had a revisit to the ER. 19 out of them had home oxygen saturation less than 92%. So you could imagine if these persons were not monitoring their home oxygen saturation, they wouldn't know what was going on, right? And some of them were not symptomatic at all. And of the patients who returned, 22 ended up being hospitalized. 8 of them were admitted to intensive care units. 6 out of those 8 had home oxygen saturation less than 92%. These were patients who initially presented as mild cases of COVID-19, right? Of the 28 who had returned to the emergency department, 60% had a home oxygen saturation less than 92%, and 29% returned solely because of oxygen saturation problem in the absence of symptoms progression. And so you could see that it can be a big problem. And actually 2.6% of these patients died. And so the conclusion is that given 10% of these outpatients were admitted to the ICU, 2.6% of them died at follow-up. Pulse oximetry is an enticing low-risk intervention which seems to help identify decompensating outpatients with COVID-19. And I think we need to emphasize this. We need to emphasize it a lot, because we do see patients, certainly in our emergency room, we do see patients who were sent home and they returned and ended up in the ICU. And some of them just they just stayed at home for too long because none of them monitored their oxygenation level, and some of them were not taught how to do it. Just a note on some of the pitfalls regarding pulse oximetry very quickly. Well, basically in this Annals of the American Thoracic Society, this journal basically looked at pulse oximetry for monitoring patients with COVID-19 at home and brought out some of the potential pitfalls and provided some practical guidance with it, especially in persons of color. So if we're going to send persons home on pulse oximetry, we basically have to teach them, and basically train them on how to use it. And I'm sure that a lot of persons will know what to do quite easily and will be able to monitor themselves at home. Now, this also basically is another journal which was actually also carried in a press, the Medical Express, that more health, it was entitled More Health Inequality. And that's because basically it showed that Black people were 3 times more likely to experience pulse oximetry error. So pulse oximeters are imperfect, especially for Black patients. We know that. We should use it with caution also. Should not be used solely for triaging of patients. Although more invasive, we recommend that arterial blood gases should be used more readily in patients that present in a hospital with symptoms. Right. This is another journal article that looked at, the limitations of pulse oximeters, again, especially in Black. And this, the reason we want to emphasize this a little bit more is because pulse oximeter is also one of the major ways that patients are triaged in the ERs, in most ERs, So in the Black population, we also need to be quite careful that we are not sending home, moderate to severe hypoxemic patients simply because we are not interpreting the result of what we're seeing properly. So we need to know, especially for the physicians who manage this patient, they need to know the limitations of just simple pulse oximeters, even though it's an extremely valuable instrument. And when patients come in with symptoms, and to be very careful how we interpret and triage patients. So we essentially looked at some of the things that we basically use in assessment and investigation of severity of illness. All right. So the neutrophil lymphocyte ratio, things that would impact on oxygen impairment, such as the partial pressure FiO2, should be calculated whenever we can, or the SpO2 FiO2 ratio, the oxygen index, oxygen saturation index. These are other ways that actually can allow us to risk stratify the patients much better. And once patients come to the hospital, we should use these tools. We should use them because these are things that help us to progress, to identify the patients that are likely to be problematic, patients that are likely to go downhill, and to manage these patients timely and appropriately. These are proven therapeutic interventions. Chest radiologic imaging is something I would like to speak a little bit about, because radiologic imaging should be considered in the management of COVID-19, especially the plain chest CT. All right, plain chest CT scanning in patients with COVID-19 associated pneumonia, we typically have findings. I mean, some articles, and appropriately so, basically say that a negative plain chest CT or high resolution CT chest essentially rules out a severe COVID-19 infection. It's not diagnostic. That's not the purpose for it. That's not, the American College of Radiology does not recommend it for diagnosis or screening, even though it does have a very good diagnostic yield. But instead, in terms of it reserves it for the management in hospitalized patients. If you have a patient with a negative plain CT of the chest and with pulse oximetry saturations in excess of 94, you can be rest assured, at least at that particular point in time, that patient is most unlikely to have any severe form of COVID-19. Again, with the same problem we see with pulse oximetry, we do see with CTs, and a lot of studies have shown that the unwillingness to conduct these images, or in fact, or even to request the images in various emergency departments, and so we basically missing out on a very useful tool. In this particular study that looked at the use of CTs and images in various patient population group, it essentially showed there was a lower odds of undergoing radiological examination in patients that were in the minorities, the Asian race. This was in the US, the Asian, the Hispanic, the Blacks, or where there was high rates of poverty, unemployment, or persons with chronic disease. Again, we see here that there were quite inequities in diagnostic radiology utilization, and these are some of the things that need to be addressed, so that decisions can be made. We sometimes wonder why it is that there's been a disproportionately high number of deaths in persons in certain socioeconomic classes. These are some of the reasons, because the things that need to be done are not sometimes being done appropriately. So we need to keep a very close eye on that, so we don't have the same pitfall. Now, what are some therapeutic interventions that can be classified as WITs? Prone positioning has been shown to improve oxygenation and outcomes in patients with moderate to severe ARDS who are receiving mechanical ventilation. This is directly from the NIH and the National Institute of Health in the US. All right, these are studies that were looked at. Prone position is extremely useful, especially in mechanically ventilated patients in improving oxygenation and actually ventilation. All right, in a case series of 50 patients with COVID-19 pneumonia who required supplemental oxygen in New York, the awake prone position improved the overall median oxygen saturation of these patients. So we basically have another tool there, which we can call a WIT. It's a useful tool, and it should be used more regularly. All right. Now, this is another WIT, another tried and proven therapy. In patients whose simple oxygenation by nasal cannula or face mask is insufficient and need to require more advanced oxygen therapy, the high flow nasal cannula is a preferred means of oxygenating patients. And I would dare to say that every emergency room should have some high flow nasal cannula, because these are very, very important and very useful devices that can rapidly improve oxygenation in this patient. Bear in mind what I said earlier, that acute hypoxemic respiratory failure is the commonest and the leading cause of death in patients with COVID-19 disease. And so correcting this problem as quickly as possible is important, because if it's left uncorrected, these patients progress to develop hypoxic injury involving several organs and end up with multi-organ dysfunction or failure. And so basically, in patients who may fail simple oxygen therapy, high flow nasal cannula system should be used, and I want to recommend it as strongly as we have recommended the use of pulse oximetry at home, also that these be present in every emergency room in Jamaica. Now, very quickly, what we look at there is just basically a graph that essentially shows us the kinetics of the COVID-19 infection, moving from the time of infection to the things that tend to happen in patients. I will revisit this a little later. And this graph gives us the time course from infection to what happens several weeks down the road. And these are important because without the knowledge of these kinetics, appropriate therapy and intervention is highly unlikely, because we would not know what phase this patient or the patient is at a particular point in time and what kind of therapy or intervention is likely to work. I quickly move on to corticosteroids. Corticosteroids are very one of the most important therapeutic in terms of pharmacological therapeutic that has been made available for COVID-19. Earlier on, persons used corticosteroid. There was a recommendation against its use, I think in May by the WHO, and that recommendation was revised following the release of this particular study, which is the recovery study that was released in July 2020. And basically, the summation of this study, this particular trial, essentially showed that there was a reduction in mortality among patients who were randomized to receive dexamethasone compared to those who did not. And so since then, corticosteroids has become one of the cornerstones of managing COVID-19. In terms of antivirals, remdesivir is perhaps the only approved treatment agent by the FDA for the management of COVID-19. And this actually came out of this particular study, which looked at about 1,000 patients that were randomized, and the study actually showed that remdesivir actually reduced the median recovery time of patients compared to patients who were randomized to the placebo group. And the conclusion of that particular study was that remdesivir was superior to placebo in shortening the time to recovery in adults, who were hospitalized with COVID-19 and had evidence of lower respiratory tract infection. This was a study that was funded by the National Institute of Allergy and Infectious Disease in the United States. Now, I look at this, looking at this particular chart, we understand that there are two main processes that drive the pathogenesis of COVID-19. Again, this is also from the National Institute of Health, that the early course of the infection, the disease is primarily driven by replication of the virus, and then in the later course of the infection, the disease is driven primarily by exaggerated immune inflammatory response to the virus, and this leads to tissue damage. So based on this particular understanding, it's anticipated that antiviral therapies would have their greatest effect in the early course of the disease. And so we saw some studies in which persons spoke to the fact that remdesivir did not work. It's highly unlikely to work when it is given late in the course of the disease, because if you've gone past the viral replication phase, it is highly unlikely that antiviral will be of any use at that particular point in time. Of course, the anti-inflammatory, especially the corticosteroid, dexamethasone in particular that was used, but other corticosteroids have also been found to be similarly useful. Methylprednisone, prednisone, hydrocortisone have been found to be equally useful as well. And they have, equivalent dosages that have been recommended for use where dexamethasone is either unavailable or cannot be used for one reason or the other. The beauty about the corticosteroid is that it works almost at every phase of the condition, because inflammation, early pulmonary phase and the late pulmonary phase sets in, and corticosteroid have found use in all of these phases. These are the COVID-19 treatment guidelines from the National Institute of Health and the recommendation for pharmacological management of patients with COVID-19 based on disease severity. And so these are very useful guidelines for us to take a look at. I'm not going to go through them in details because of time. Anticoagulation is another tried and proven therapeutic for hospitalized patients. Prophylactic use of anticoagulation should be prescribed unless contraindicated. And this is a direct guideline from the National Institute of Health. And so we know that COVID-19 is a very procoagulant and highly thrombogenic condition. And so we should bear that in mind in the management of patients with COVID-19. The question is not that of anticoagulation. The question is whether or not it is prophylactic coagulation, or we're actually doing full anticoagulation in this patient. I think at this particular point in time, that issue should be settled, and all clinicians should be aware of the need for at least prophylactic anticoagulation in these patients, because especially the patients who become critically ill, low molecular weight heparin or unfractionated heparin is the anticoagulant of choice over oral anticoagulation because of their shorter half-lives and their ability to be administered intravenously or subcutaneously and fewer drug-drug interactions. Now, quickly, I wanted to speak very briefly on ivermectin. It's practically impossible to talk about ivermectin without talking about the Frontline COVID-19 Critical Care Alliance, which I just quickly introduced. This is a group of doctors led by Professor Paul Marik that have taken it upon themselves to continuously review and rapidly emergency basic science, translational and clinical data to develop a treatment protocol for COVID-19. And they've put out a number of articles, they put out a number of recommendations, and in one of those recommendations that they have put out, looking at the evidence, they have looked at ivermectin, and they have spoken very vociferously on the use of ivermectin internationally as a group, and that has led to it being discussed worldwide. It's probably one of the most widely discussed issue at this particular point in time, and various countries are looking at the studies and the recommendations from this group. Certainly here in Jamaica, it is being reviewed by the clinical working group, and I'm sure very shortly we will see a response from the ministry regarding that. Right, these are some of the guidelines that our protocol management guidelines that have come out from this particular group, the FLCC group. or previously known as the EVMS COVID-19 management protocol. These are some persons may be familiar with this protocol known as the MAT Plus protocol or the IMASC protocol as well. So these are protocols that have been put out there that look at the various things for the management of COVID-19. They look at not just pharmaceuticals like steroids, but they're also looking at supplements such as vitamin C, thiamine, the use of anticoagulant, like we said, and other multivitamin agents, the use of statins, vitamin D, famotidine, melatonin. These are things that have found their way, and there have been a lot of discussions around it. And they've been provided also not just as protocol, but they've also been provided with dosages and guidance on how to use them. And so we basically, these are things that need to be looked at, and also data collected on them. We're pretty much aware that a lot of persons are already using these things in various dosages and with various recommendations. Data perhaps need to be collected on some of these things so that we actually can say whether these are wheat or chaff. Now, their basic scientific rationale for the MAT Plus treatment protocol is essentially basic science, which I'm sure many of us are already aware of: hyperinflammation phase, hypercoagulation, and the severe hypoxemic situation that occur as a result of this. Now, the hyperinflammation, which is dysregulated immune response, where cells infiltrate and damage the lungs as well as other organs, including the heart and the bone marrow. Hypercoagulation, increased clotting, that is as a result, again, of a dysregulated immune system that damages the endothelium and increases blood clotting by activating clotting and causing formation of micro and macro blood clots, thrombi, and emboli formation. And these are some of the things that are believed to have led to some of the poor outcomes in COVID-19. ACE2 receptors are present on platelets, and they also play their role in clot formation and impairment of blood flow. All right. In conclusion, I'm pretty sure that my time is pretty much up. In conclusion, COVID-19 is a novel condition which has resulted in over 2 million deaths. Several phases have been described, and patients pass through these phases with different outcomes. There are diversity of response to different therapeutic agents. The most important factor is time. I cannot overemphasize the need for timely intervention. Time is perhaps the most important thing in the management of patients with COVID-19. For every day that inappropriate treatment or management protocol is activated, for patients who go on to develop hyperimmune phase or end up with ARDS or end up with significant clot formation with micro or macro thrombi involving the pulmonary system and ultimately leading to severe hypoxemia, time is the most important factor. Appropriate and timely response to infection is critical to good time, to good outcome. In addition to time, I want to talk about aggressive and appropriate response. We've seen patients that have been taught to pretty much okay. Patients who were sent home, they came to the ER, they were sent home because they looked pretty good, and by the time the patients return, it's just a different patient, and in some cases with poor outcome. So appropriate and investigations of these patients are important. Not triaging of patients, so many other factors need to be taken into consideration when we triage patients, especially when they visit our ER or they visit our various facilities where we see these patients, not just the ER, but wherever we see these patients. How we triage these patients are important, and timely response is important. In this case, time is life. And I just want to say thank you again, Dean Paul and Professor Christie, for inviting me to present at this conference. And I hope that as we progress, we continue to see a decrease in mortality and an improvement in our morbidity in COVID-19. And thank you.
I want to thank Dr. Metalov for taking us through that path of looking at the treatment options. Thank you very much for sharing the details and looking at the trials and what is current, what is new, what is established, and what we can put aside at this point. Certainly, it is still a challenging area for COVID-19, and I think when we hear Dr. Metalov's talk, there's a bit of reflection back to Peter Figueroa, some of the other speakers, again, talking about the role of pharmaceuticals, but also the role of non-pharmaceuticals and bringing a balance to the table. But certainly, I think we're leaving from that talk with some hope that there are options too for severely ill COVID-19 patients that one can bring to the table during their hospital stay and so on. So thanks again very much, Dr. Metalov, for your contribution and for sharing with us today at this teleconference. Thank you, sir. We heard earlier on from Professor Figueroa that we are in a phase where we now have vaccines at our disposal for managing the pandemic. And I understand that there are, to use Jamaican patois, a whole heap of vaccines out there. There's like some, I think over 60 that are in clinical trial and another 90 in preclinical phase and so on. But we need to hear more about that, and we need to, our topic coming up next is getting ready for the COVID shot. Are you ready? We have a distinguished speaker who is going to address us on this topic. We have Professor of Pediatrics, Infectious Disease, Epidemiology, and Public Health in the Department of Child and Adolescent Health here at our very own University of the West Indies, Jamaica. And this speaker is a distinguished professor who is known for her excellence. Excellence in her clinical work, excellence in her research work. She is a leader in clinical trials and vaccines, on drugs and vaccines. And she has done excellent work, in fact, on the rotavirus vaccine, which is a vaccine for gastroenteritis. That trial was back in like 2006, 2009, that period. And in fact, the work that she did with others and was published received International Award for Excellence in terms of that publication and the actual impact of the work. Also, she has received Excellence in Science Award for National Immunization Program from the Center for Disease Control and Prevention in the USA. She sits on a number of task force, regionally, locally, on the CARFA Task Force, Caribbean Public Health Association, expert group on COVID-19. She also sits on the Commonwealth Medical Association panel of experts on COVID-19, and much, much more. Ladies and gentlemen, it is my pleasure to introduce our distinguished speaker this morning on getting ready for your COVID shot, Professor Celia Christie.
Thank you, Dean. It is my pleasure, my privilege, and my honor to speak to you today on preparing for your COVID-19 shot. And so we have all been very concerned about the toll of COVID-19 in the world, in the region, and indeed in Jamaica. Globally, we have heard of the over 95 million cases and 2 million deaths that have been reported. Community spread and second and third waves are present in several countries. We have also heard about the mutations with some 70% increased risk of transmission. Herd immunity from natural infection leaves too many lives and livelihoods lost. And therefore, we have an urgent need for safe and effective vaccines. So the purpose of today's presentation is to go through for you the science of COVID-19 vaccine development. I will review for you peer-reviewed published data on vaccine safety, immunogenicity, and efficacy for some of the leading candidate vaccines, and speak to the relevance of these as this relates to Jamaica and indeed the Caribbean. So the clinical phases of SARS-CoV-2 vaccine development have been accelerated by prior knowledge of the spike protein in coronavirus pathogenesis. Neutralizing antibody against the spike protein is important for immunity and rapid evolution of the nucleic acid acid vaccine technology platforms has allowed the creation of vaccines and prompt manufacture of millions of doses of vaccines once the SARS-CoV-2 genetic sequence was known. Activities for research have been conducted in parallel rather than sequentially, as we are accustomed to in the past. This without increasing the risk to our subjects. And so we have gone through the preclinical phases of vaccine development and the clinical phases of safety and immunogenicity studies, and safety, efficacy, and regulatory approvals in a very short timeline of just 6 months as compared to the 6 to 20 years that we were normally accustomed to. This is an outstanding and absolutely amazing feat. And so when we look at the SARS-CoV-2 vaccines that are in development, we have the whole inactivated virus, we have the live attenuated virus, we have the protein subunit vaccines, and we have the virus-like particle vaccines, and those we are accustomed to because these are the classical vaccine platforms. New vaccine platforms, however, have come on board, and these have included the viral vector vaccines, the DNA vaccines, the mRNA vaccines, and the antigen-presenting cell vaccines. So today, the WHO tells us that we have over 64 vaccines in clinical evaluation. 21 of them are going through phase 3 or phase 2 to 3 studies. 23 are going through phase 1 and 2 or phase 2 studies. And 20 of them are in phase 1 studies. And there are over 173 candidate vaccines that are in preclinical development. Amazing indeed. And so I will speak to you first about the Pfizer-BioNTech mRNA BNT-B2 vaccine. This vaccine I will tell you more about as it relates to its immunogenicity, its safety, and its efficacy. Regulatory approval has been received for this vaccine in the UK and the United States and in several other countries, including here in the Caribbean. There are several Caribbean countries, certainly from the UK territories, that are taking this vaccine now. And I should also say that this is the only vaccine to date that has received WHO approval. And so, these RNA vaccines are lipid nanoparticle formulated nucleoside modified RNA vaccine candidates. And 2 candidates were presented. BNT-B1 encodes a secreted trimerized SARS-CoV-2 receptor binding domain, which has self-replicating RNA. And then BNT-B2, which is the one we're interested in, encodes a membrane-anchored SARS-CoV-2 full-length spike stabilized in the pre-fusion conformation. And this one has a non-replicating RNA. This technology of infection makes the mRNA, which delivers the spike protein to the cells in a lipid membrane, or what we would call a micelle. And this fuses with the cells, and the mRNA they created enters into the cells and makes a genetically engineered replica of the spike protein. The final product of mRNA will then make a protein that is immunogenic and cause development of antibodies to SARS-CoV-2 spike protein when the body is challenged by natural infection. And so, looking at the immunogenicity of these 2 candidate products in young adults and in older adults who were both given vaccines at different doses, you will see here that this stimulated SARS-CoV-2 binding IgG antibody and also neutralizing antibody titers at doses of 10, 20, and 30 micrograms. These titers were found to be similar or even higher than the geometric mean titer of a panel of SARS-CoV-2 convalescent serum samples from persons who were infected naturally. Looking now at the safety of these products, and so you have adults 18 to 55 years in the upper panel, adults over 55 years in the lower panels, the first dose on the right of each panel and the second dose on the left of each panel. And you'll see here that local reactions were prevalent and common, and pain at the injection site was the most important one. Systemic reactions included fever and fatigue and chills, and these were mostly mild or moderate and not very severe. Now, in comparing the two vaccines, you see that BNT2 was associated with a lower incidence and severity of systemic reactions as compared to BNT1, and this was particularly so for older adults. So BNT2 was selected for the global phase 2 to 3 study, randomized double-blind trial, and 30 microgram was used. The vaccine or placebo was given at 0 and 21 days to over 43,000 persons who were followed for a median of 2 months for safety and for COVID-19 disease. And you'll see on the right side of the slide that demographics were balanced by sex, race, ethnicity, age, country, as shown. Males were about 50%, white race was 83%, Black Americans was 10%, Asians I think was 4%, and Hispanic was not seeing so very well. Hispanic, I think, was very, very high, 20%. And then as it's shown there, the countries were Argentina, Brazil, South Africa, and the United States. The ages were balanced, and I think up to 30-something% were obese. This slide looks at this local and systemic reactions, and you'll see that the vaccine recipients had local reactions of erythema and swelling, and systemic reactions of fever, headache, and myalgia at higher rates than placebo recipients. And these reactions occurred more commonly after the second dose. Most reactions were mild or moderate, and older recipients had fewer and milder reactions. Vaccine efficacy was found to be 95% 7 days after the second dose in those who did not have a prior SARS-CoV-2 infection. When those with and without prior SARS-CoV-2 infections were combined, the vaccine efficacy or protectiveness was 94.6%. Vaccine efficacy was 52% for those who had severe COVID, and the protection started some 12 days after the first dose. Adverse events are shown here. Some of them are summarized here. And 21% of vaccine recipients, as compared to 5% of placebo recipients, had related adverse events, and these were mostly reactogenic events as they related to the use of the vaccine. Deaths were seen in 2 vaccine recipients and 4 placebo recipients, but none of these deaths were reportedly related to the vaccine or placebo. Because of the concern of anaphylaxis, the CDC rapidly published some data as it relates to post-registration safety monitoring of this product, and they found some over 4,000 persons had adverse events, or 4,000 adverse events for some 1.9 doses of the product, for 21 cases of anaphylaxis, giving 11.1 cases per million doses. The limitations for this study is that we certainly need to get additional data on safety and efficacy beyond the 2 months than has been reported. We need to study this vaccine in children, in pregnant women, and the immune suppressed. We need to determine whether the vaccine protects against asymptomatic infection and transmission to other persons. We certainly need to know how long does immunity last, and we need to know if there are any long-term complications. And should there be anyone who would miss the second dose, we need to find out how to deal with that. So in summary, 2 doses of this mRNA vaccine were found to be safe over a median of 2 months and provided 95% protection against symptomatic COVID-19 disease in persons who were aged more than 18 years of age. So COVID-19, we now know, can indeed be prevented by immunization. RNA-based vaccines are a promising new approach for protecting humans against infectious diseases. This study demonstrates the speed of RNA-based vaccine development with investment of the appropriate resources. Let's move over now to the Moderna mRNA 1273 vaccine. We will look at its immunogenicity, its safety, and its efficacy. This vaccine has received regulatory approval in the United States and Canada and many other countries, as noted here on this slide, and it is in use in several countries already throughout the world. Looking at the cellular immunogenicity in middle-aged adults and older adults in a phase 1 dose escalating study of 2 doses at the 25 microgram or 100 microgram dose of vaccine administered 28 days in these healthy adults, you will see that the vaccine elicited a very strong CD4 cytokine response involving the type 1 helper T cells. And this response increased with even higher doses, and 2 doses were found to be needed to induce cellular immunity. In the same dose escalating study, binding antibody responses increased rapidly after the first immunization. Serum neutralization activity was detected in all of the participants using multiple methods after the second immunization. And in another study looking at the younger adults, 18 to 55 years of age, they demonstrated the similar responses in a separate study. Let's look now at the safety of this product in phase 1 and 2 studies in younger adults and in older adults. And let's look at 3 different doses, the 25, 100, and 250 microgram doses. And you will see, looking at both sides of both diagrams, that this vaccine elicited quite a few reactogenic. It was very reactogenic. And it elicited quite a few responses, both local and systemic. And what you'll see too is that the 250 microgram dose elicited very, very, very high responses, and so they chose the 100 microgram dose for the phase 3 study. Now, the phase 3 trial was done. It was a randomized placebo-controlled trial done in the United States in over 30,000 subjects who were older than 18 years, who were followed for safety and lab-confirmed illness, COVID-19 illness, 2 months after they got the second dose of the vaccine. Baseline demographic characteristics were balanced between the placebo group and the mRNA vaccine group. Mean age of the population was 51 years, 47% were women, 25% were older than 65 years of age, 17% were younger than 65 years of age, but these were persons had risk factors for comorbidities for severe COVID-19 as shown. Race and ethnicity represented the US demographics, with 79% white, 10% black, and 21% Hispanic. Local reactions occurred more frequently in those who got the vaccine. So after the first dose, the reactions were 84%, and the second dose, 89%. And the most common local reaction was pain at 86% at the vaccination site. Systemic adverse reactions occurred more often in the vaccine group as well. After the first dose, 60%, and after the second dose, 79%. Headache, fatigue, and myalgia occurred in more than 50%, whereas arthralgia and chills occurred in more than 40% after the second dose. Most of these complications were mild or moderate, and they were more common in the young. Unsolicited adverse events are shown here. There were 3 deaths in those who did not get the vaccine and 2 deaths in those who got the vaccine. Other adverse events were similar in both the vaccine and placebo recipients. These included severe adverse events, medically attended adverse events, and serious adverse events with rates as shown. Hypersensitivity reactions were reported in 1.5% of vaccine recipients and 1.1% of placebos. Bell's palsy also was identified in a few cases, and fatigue and headache also occurred. This vaccine was shown to be 94% efficacious in protecting patients from getting COVID-19. For 196 total cases reported, 11 cases only were in the vaccine group as compared to 185 cases in the placebo group. Looking at severe COVID-19, the vaccine efficacy was 100% to prevent severe COVID-19 disease. meaning then that all 30 cases of severe COVID occurred in persons who did not get the vaccine. Vaccine efficacy was also found to be consistent across all the subgroups as stratified by age, sex, race, and risk factors for severe COVID-19 disease. So we need to further determine the safety and the efficacy in a larger population over a longer period of time, and also in pregnancy and in children. We need to know if the vaccine protects against asymptomatic infection and transmission to unvaccinated persons, and we need to know how to care for those who missed the second dose. So in conclusion, 2 doses of this vaccine were safe and 94% efficacious in providing protection against SARS-CoV-2 infection in adults older than 18 years of age. So 1 year after the emergence of this novel disease, a pathogen was determined, vaccine targets identified, vaccine constructs created, manufacturing to scale was developed, and testing was done and conducted, and the data have now been reported formally. The AstraZeneca vaccine is the other one I'm going to speak about, and similarly, I'll go through immunogenicity, safety, and efficacy. This vaccine has had a regulatory approval first in the UK and then subsequently in several other countries, including here in Latin America. The United States FDA will look at the data for this study, for this vaccine, on the 21st of January. So this is a prototype of the non-replicating viral vector vaccines using the adenovirus construct. They use this chimpanzee adenovirus, which is modified so that it is unable to cause disease. And then they clip a bit of the spike protein from the virus and splice it into the adenovirus and make it into the vaccine. This is then injected into the patient or into the person, and the cells then express the spike protein, and the body produces antibodies against the spike protein, so that when the person is exposed to SARS-CoV-2, the immune system attacks the SARS-CoV-2 and neutralizes it. Here we have the safety of the product in 560 healthy subjects of diverse ages in 2 UK centres. And you'll see here that local and systemic reactions were more common in persons who got the vaccine as compared to those who did not. These effects were higher for local reactions in the young people for 88% as compared to the older group for 61%. And systemic reactions also were similarly higher at 86% versus 65%. Here we see the immunogenicity of the product, that SARS-CoV-2 increased IgG response to the receptor binding domain and the spike protein when we looked at 5 different age groups comparing the standard dose and the low dose groups. And here we see the immunogenicity as well in the 5 age groups, and you will see that this was increased for neutralizing antibody and for the T cells. Looking at the safety and efficacy of this product in 4 blinded randomized controlled trials across the UK, Brazil, and South Africa to ensure that there was diversity in race, ethnicity, age, and comorbidities. You will see here that participants who got the vaccine in 2 doses as a standard dose, and there was a subset in the UK who got a low dose of the vaccine and a standard dose. And essentially, for 11,600 participants, there were 131 cases of COVID-19 in the UK and Brazil. And the efficacy for those who got the 2 standard doses, vaccine efficacy or protectiveness, was 62%. For those who got the low dose followed by the standard dose, vaccine efficacy was 90%. And so the overall vaccine efficacy across both groups was 70%. And now we look at safety. There were quite a few events that came to the public attention, and there were stopping rules. And I'll just mention some of these here. There was transverse myelitis reported in a person who got the booster after the booster dose of vaccine. It was called short segment spinal cord demyelination by the Independent Neurology Committee. There was also 1 case of hemolytic anemia and another case of very high fever but those were okay. And then there were 2 other cases of transverse myelitis that were not thought to be vaccine related. One actually linked back to a patient who had unrecognized multiple sclerosis, and the other one was in a vaccine, the other patient had gotten placebo. And there were 4 non-COVID related deaths. So in conclusion, the AstraZeneca Oxford vaccine has an acceptable safety profile and is 70% efficacious against symptomatic COVID. There were no hospitalizations or severe cases in persons who got the vaccine. This vaccine can be stored and distributed at 2 to 8 degrees centigrade, and therefore it is suitable for global distribution. The FDA and the WHO had said before that they will accept a vaccine against the pandemic virus that showed at least 50% efficacy. So this then is the first peer-reviewed study showing that induction of immune responses against the spike protein using viral vectors provides protection against symptomatic coronavirus disease in humans. And then the 4th vaccine that I want to speak about is the Gamaleya Sputnik GamCovid vac, which was registered in Russia last year, and that product has a vaccine efficacy of 91.4% in over 18,000 volunteers. The study is still ongoing in 40,000 volunteers, and they have also used against a well-studied adenoviral vector, and this product has had given out over 1 million shots in Russia, and it is approved for use in Palestine, in Belarus, in Argentina, and in other countries. And then I'll summarize for you just a few more studies, because this is what the WHO would be looking at as it relates to the Caribbean. And here we have 3 vaccines from China. China has said that they are going to commit to make vaccines for the world as a mark of soft diplomacy to more or less offset the pandemic and to more or less help to get that pandemic to go away. So this is Sinovac, Sinopharm, and CanSino, and the top product there is Sinovac, which so far in 2 countries, it is said that it has shown efficacy of 50 to 70%. The other 2 are being used in other parts of the world. All of them are being used in China. Phase 2 data has been published for all of them, and phase 3 efficacy data, published phase 3 efficacy data that we can review is supposedly imminent. Here we have 3 other vaccines that the WHO is also interested in. There is a Johnson & Johnson vaccine, which is very interesting because you see this one you may be able to use just 1 dose. And then there's a Novavax, and these studies are ongoing in the United States and in UK and Mexico. Phase 2 data are available, and phase 3 data should become available sometime later this year. And then India has 2 vaccines, one of which is shown here, and which is already being used to immunize persons throughout India and in other parts of the world. Caribbean initiatives included an invitation that was extended to the university based on our experience in the Rota trial, and the acellular pertussis vaccine trial, our experience with the pharmaceutical industry and vaccine trials, and the FDA's Anti-Infective Drugs Regulatory Advisory Committee. And so they invited us, the Bill Gates Foundation did, to compete for a clinical trial site infrastructure grant to enroll some 800 subjects per week, beginning January 2021. We figured we would need something like 10 clinical cubicles. We'd need a call center with about 30 cells, and the material, administrative, and human resources to do this. And the vaccine that they were interested in would have been CureVax. That's now up and running in other parts of the world since January. Cuba is not to be outdone. Cuba has some 4 vaccines that are in clinical trials, and Soberano 1 is in phase 3 trials, and Cuba is insisting that they will be able to immunize up to half of their population by the end of first quarter. And then we go to the COVAX facility. But the 10 vaccines that are under consideration are shown on the left of the slide, and you'll notice that AstraZeneca Of the 10 billion doses that are being made in 2021, AstraZeneca vaccine is the one that is most attractive to people all over the world and to the WHO and so on. Going right down to the top 4 that I mentioned that have had regulatory approval, and then the other 6 that I mentioned briefly. And COVAX, as you heard from Prof. Figueroa, is this global risk-sharing mechanism for pooled procurement of equitable access of COVID-19 vaccines to access over 2 billion doses for participating countries and economies, and with the hope of ending the pandemic by 2021. These vaccines must be safe, effective, must be regulatory approved, or have WHO pre-qualification, and as I said before, 10 of them are under consideration even now. Vaccines must be available, they must be a little bit on the cheaper side, and there must be logistics as this relates to shipping, refrigeration, storage, and administration. Jamaica has been included with funding from CARFA. Thank you, CARFA. On the right side of the slide, though, I just want to bring to your attention that despite the fact that COVAX is doing this, you'll notice at the end, it's right at the bottom of the list as it relates to, whether or not we will get this. Canada, it is said, have pre-ordered some 9 doses per person, 9 doses of vaccine per person, and the United States and United Kingdom are not too far behind. So we have to wonder if we will be able to get these vaccines into third world countries such as ours. The Vaccines Commission has been set up by the Jamaican Ministry of Health as of the 8th of December, as announced in Parliament, with multidisciplinary membership, with the goals to guide and oversee the development and implementation of a national COVID-19 deployment and vaccination plan. And the goal is to vaccinate at least 17% of the population, starting with our healthcare workers and persons who are over 60 years of age, and then going for essential service workers. So, in conclusion, I believe I would have shared with you that we now have over 64 SARS-CoV-2 vaccines that are in various phases of clinical development. Several vaccines have already received regulatory emergency use authorization, and the safety, immunogenicity, and efficacy data approaches some 70 to 95%, and the peer-reviewed published data is available for all of us to see. Global distribution of these vaccines began in 2020, and we hope that Jamaica and indeed the Caribbean should at least begin receiving our vaccines beginning in second quarter of maybe from the COVAX facility, or who knows, from other initiatives. The duration of vaccine immunity, response to boosters, and mixed schedules, amongst other things, are, however, unknown. And herd immunity, whether from vaccines or from natural infection, will likely be unlikely before another year, according to the WHO. And therefore, as we have heard, and it's as part of our New Year's resolutions, we need to continue those preventive measures, whether or not we get the vaccine, or whether or not we even have COVID. Let's hope we don't get it, but still, we must maintain physical distancing, face masking, and the appropriate hygienic measures. So, I suppose, having shared with you the data, the scientific data, I am encouraging you that it is now time to roll up our sleeves and take that COVID-19 shot when it is offered to you. Thank you.
Thank you very much, Professor Christie, for the enlightenment on the current state of COVID-19 vaccines. And very encouraging news. Listening to Prof, I'm hearing that the vaccines are, well, certainly those that have come out that we're using now, they have high levels of efficacy, and the safety profile looks quite encouraging, certainly, in terms of the side effects and so on. I have a question for Prof. I think overall what I'm hearing is the COVID-19 experience with vaccine production, it appears, and Prof, I may be wrong with this, has brought to light the application of technologies in where we are now in the world in terms of how fast we can prepare vaccines and the safety and efficacy. You had mentioned earlier that they've used nanotechnology when you're looking at the RNA, the nanotechnology to produce this vaccine. And we have a wide audience here listening this morning. I know we have physicians, nurses, health providers, and we have members of the public. Maybe two questions in one. One, I get this question from persons all the while. How come they made this vaccine so quick? And therefore, I don't trust it because they make it so fast, so quick. If you can speak to that and a little bit about nanotechnology, is that a part of it and why we're getting it so quick and better? Really, just a comment on that, Prof. Thank you.
Yes, thank you very much for that question. And essentially, what has happened is that since when SARS-CoV-1 and MERS came up on board, there was quite a bit they were trying to do quite a bit then, even from then, in making these vaccines, in trying to make these vaccines. And what happens is that as time went by, MERS went away and SARS went away, but the technology was still being developed. And therefore, once the SARS-CoV-2 came on board and they knew about the genetic sequence, because as you know, that became known in like about a week. The genetic sequence was known, and folks went back into their freezers and into their laboratories and more or less continued, and more or less tried to make this become available. The nanotechnology, what they're trying to do is they have actually spliced a bit of they know that the spike protein is important for immunology, to develop an immunological response. And what they had to do was to sort of keep the spike protein in the pre-fusion conformation using a long list of various fats and polyethylene glycol and lots of different fats and so on, and sort of kept it in the micelle formation. And once they could figure out how to keep that going and maintain the pre-fusion formation, they were and before it gets into the cell, that was able to make a difference. In fact, my understanding is that now that this has happened, the technology has more or less taken off. So it's not just about SARS-CoV now, it's about lots of other technologies that are being applied based on this. So it's like a brand new world that has opened up.
Prof, is this one of the more efficacious vaccines we're seeing? Your experience with vaccines, in general?
Well, what was interesting is that we accept the influenza vaccine. We take the influenza vaccine even when it is just 30% efficacious. There are times when it was that low. But what the FDA and the CDC did is they published, before the studies were done, they have published data which show that if the SARS-CoV-2 vaccines were 50% efficacious, they would be willing to accept it. And then, wow, we suddenly find that we have vaccines that are 94%, 90, 95%, 70% efficacious, which is, way above our wildest dreams. Yeah. And even the thing about it too is that the influenza vaccine, remember each year we make a new vaccine because because it changes. And even though there's quite a bit of concerns about mutations and so on, we feel that maybe for now the vaccines will work against the mutant strains that are out there. But as time goes by, if the virus even mutates, we already have the technology to make a difference, to make the vaccines to fit the strains that are out there. So hopefully, it's really a brave new world that we have entered in as this relates to SARS-CoV-2 and the vaccine technologies that are out there. So let's see what we have to offer.
Thanks, Prof, for that enlightenment. I think we had a bit of a head start, as Prof was saying, with the prior epidemics that we had with coronaviruses, and so we were able to move very quickly to get these vaccines to the table. And we in the Caribbean, we're not afraid of speed. We have Usain Bolt, Atta Bolton, we have Merle Naughty, the list goes on. We have Courtney Walsh, Mikey Holding. So we are accustomed to doing things well and quickly. And the encouragement is that as the vaccines roll out, we do hope that the COVAX facility and any other public health strategies that we're taking to get these vaccines on the shores of the Caribbean, that we can get that sped up, and that we can have access, and that, again, people will be encouraged. As Professor Christie says, our regional vaccine trials expert, Prof. Christie says in her last point this morning, roll up your sleeves and take that COVID-19 shot. That's encouragement. Prof, thank you very much for an excellent talk in both scientific enlightenment and our enlightenment to our community to have confidence and to go forward in terms of fighting the pandemic. So you have joined us for our Making New Year Resolutions COVID-19 conference. We thank you again. I know our audience is swelling and growing as we speak. Please put your questions and your comments in the chat. We are here to respond, and we will give you feedback and answer your questions as best as possible. The COVID-19 pandemic is, what I'll say, is very pervasive. We heard this morning about the epidemiology, we heard about the clinical features, but when our own experience, even from last year to now, I'm sure personally in all our lives, we have seen impact that spreads across the health aspects and goes right into the issues of the economy. I've had to be ordering food sometimes rather than going out, and see these delivery systems coming up, and more online payments and all kinds of things. And then of course you hear the big people in government saying, boy, tourism taking a beating in the economy and so. So we cannot have a teleconference without really looking at the economic issues, the economic projections. In fact, I'm very proud that back on March the 5th, our very first teleconference, we spoke about the economic issues. Even then, before COVID had landed on shore fully, we were cognizant that there was going to be economic impact. And I'm also very happy to say on March the 5th, we had a distinguished speaker, economist, presenting then. She's a lecturer in economics in the Faculty of Social Sciences here at UWI Mona. Her area is public finance. She's a member of the board of the Bank of Jamaica and is conducting research on a range of issues relevant to economics and society and social economy and well-being in Jamaica. Ladies and gentlemen, my pleasure to introduce Dr. Christine Clark, who will speak to us on COVID-19 economic projections for 2021. Let's welcome her.
Good afternoon, colleagues. Thanks very much, Dean Paul, for the invitation again. It's good to be here and to give an updated view and maybe some considerations for Cabinet as it goes into retreat to consider all the issues going forward. So I would just like to start by giving the audience just some idea of what are some of the economic perspectives that are now relevant. We would have spoken broadly last year, having not known or had an idea of as to how exactly COVID-19 would have impacted Jamaica. But having seen it over the past 10 months, we realized that, it is really one of those low probability but high impact shocks that we just never have seen or haven't had to grapple with in the way that it has manifested, given the improved trade and also travel patterns that have impacted its ability to spread. And so the problem that leads to is what we call in economics is market failure issue. And you'll hear me talk about that as we go through, these market failures. Because what it implies is that there's going to be a role for the state, as we have seen, various ministries, departments, agencies all over who you would not have associated with a health shock have had to step up to the plate. Local government, Ministry of Labor, all of these entities, Ministry of Education, have been impacted. And so the state will find itself and has found itself playing a more important, a more direct, a more dedicated role as we even saw with, the frequent press conferences televised, and eventually, I guess because of its ubiquity now on social media. So our interventions have happened, but of course, one of the important and interesting things about economics is you have to understand that culture really matters. And we see it in Jamaica where, the same exact state interventions implemented have different impacts, have different implications. People view them differently. And so there have been adverse behavioral reactions, maybe at the outset when there was a higher fear factor. You had more persons adhering to them, but we've seen the reports from the police, the parties, etc., that have been happening. So we have the infection and prevention control measures, but we've seen some adverse behavioral reactions. And then we have the issues of the economic impacts. Yes, as Dean Paul mentioned, there are impacts on the big players, of course, the tourism, the big names, the big chains. But then even more so, and maybe less understood, is the impact on the kind of subsistence or remote livelihoods that may not have been as plugged into these major kind of hubs of economic activity. How do they navigate given the need to go basically digital, to go direct to market and those kinds of things? And then there's the issue of the resistance to the virus in terms of, as I said, the knowledge, attitudes, practices. People, even last evening, a couple evenings ago, persons on the TV saying they don't believe in the virus, they don't think it's necessary, why do we need a vaccine? So that the KAP is still indicating to us that there still needs to be effort as far as this is concerned, because of course this impacts the economic. We're not going to get very far if we don't have enough adherence. And then, as I indicated, the skepticism towards the vaccine. So the behavior change is important, and I think from the economic perspective, what we would want to see is the consistent, continued communication. That has to be part of what we do to weather or to navigate where we are. So I'm providing the numbers. These numbers are courtesy, of course, of the Statistical Institute of Jamaica. They're quarterly updates. And we just want to maybe look at the highlights, of course. I'm sure if the presentation is required, it can be circulated for more details. But I'm just highlighting in the final column here, the third quarter. So we have not yet had the full numbers for the calendar year. So we are up to July to September. And what you're able to see here is that there's been mixed performance. Whilst we would have thought, kind of landslide declines, which we've seen in some areas, notably, as Dean Paul referenced, the hotel and restaurants, which kind of point us largely to tourism, which declined by 65.2. I've tried to circle the ones that are declining, but declining at a slower rate and thereby improving the overall performance for GDP. To be seeing, yes, there's a decline, but it's not as bad as it was in Q2 when we had the lockdowns, we had our workplace clusters, we had, just general scaling back of economic activity. That decline was about negative 18.4. For the Q3, we're seeing negative 10.7. So the quest for growth that I would have referred to in March last year, where we had just completed, to I think worldwide acclaim, or extended fund facility. We had gone through the precautionary standby agreement ending in 2019. And so we were looking forward to having, this kind of growth uptick that has clearly been stemmed by COVID-19 and the IPC measures, etc. But we have some positives here. Again, as usual, agriculture being one of our saviors, albeit usually from a low base, but in terms of growth, we're seeing an uptick of 2.5%. Construction is the other one that we probably are going to see continued uptick in, and I'll speak to that just from the perspective of government investments in infrastructure, repairs, etc., that are happening, and then the government sector itself, small but still positive, 0.1% growth. So overall, what we are seeing based on the data we have so far, I believe Statin will probably will come with new data soon. For Q4 up to December, we'll see, kind of that Christmas effect and what we were looking for in the winter tourism season. So this is kind of the summary, and we can talk about, how the different sectors might play through going into 2021, even to the end of the year. As I indicated, agriculture, usually one of our saviors, but we know that that was impacted in the last quarter by the heavy rains, the consistent, persistent heavy rains that would have had some negative impact. So we're going to have to watch that one there. In terms of construction, as I indicated, we see the real estate activity happening as far as new builds around the corporate area. And so we might continue to see positive numbers there. And as I said, GOJ, very active now. We've seen the rollout of the broadband initiative, which may yield further growth there. On the declining side, as I indicated, these are just an excerpt. I mean, the declines are slowing, but for mining and quarrying, I think there may be a bit of a concern. There seem to be more structural issues, yes, impacted by COVID, but going through a kind of maturing evolution, and so not sure where exactly that will turn out. For transport and communication, I believe if construction continues to be a bit robust, we might see more activity on the transport side. And I am hearing the renewed talks about a logistics hub. Not sure exactly where it will go, but maybe that is one of the things in relation to economic activity. And certainly with the broadband initiative, the communication dimension of that subsector should be important. I think as far as WR Trim, that's our wholesale retail trade section, we are going to probably need, a couple more cycles, because as we, can imagine, our downtown areas and our markets will need to, as it were, infuse far more CRM measures, customer relations management. So who are your buyers? Who are you targeting? Who do you sell to regularly? How can you reach them without them having to, necessarily come in person? Those things, and I'll talk about some of the things that will need to happen to get some of these kind of small value transactions, digital. How efficient will that be? And then the continued challenges, of course, for the hotels and restaurants. As indicated, we were hoping for a good winter tourism season with the reopenings, and then we had a new variant. So that kind of stymied the efforts, especially out of the UK. And so it remains to be seen what we will be able, what the authorities in terms of the Jamaica Tourist Board and the ministry and the minister himself going really hard at the market and trying to demonstrate that Jamaica has a response. Recently, hotels are advertising that they're doing testing on site. So, to facilitate those who need a test before they leave, etc. So we're having some responses, but then to what extent can persons from the host markets actually, come to Jamaica based on the lockdowns that they may be experiencing? So those are some of the things. So overall, it is possible that we have some good headwinds for growth. One of the major indicators highlighted by the Bank of Jamaica as well as Statin is the alarming robustness to remittances. At the start of the crisis, even before the Caribbean had experienced its first case, the World Bank had projected double-digit declines in remittances. I guess just extrapolating, perhaps from the last crisis, which we would have known. I mean, it's a good strategy to use the most recent crisis, which was the 2008-9 global financial crisis. But as we've seen, because the jobs, it appears that Jamaicans in the diaspora pursue are in high demand during COVID, we've actually seen increased remittances during the period. So that's one of the good things, in that it helps the purchasing power, clearly, of the average Jamaican who will still need to find a way to survive. There are some positive headwinds also coming from the employment. BPO sector indicating that they're almost back, I think, to pre-COVID levels. They're employing more persons as they work out the legal requirements to have persons work from home, but still perform to the level that they're required to in terms of confidentiality of information, etc. And we see more efforts in terms of testing, not just at the public health facilities. There are now private institutions coming on board. And as I indicated, the hotels also engaging in trying to give this service to potential tourists. And then the issue of the digital divide, more devices being distributed, being procured. And so there is hope, at least over the medium to long term, that that would be a positive headwind, heading off some of those inequities that we certainly don't want to be entrenched, and we certainly wouldn't want them to widen any further. On the negative side, as I said, we're still not sure what this negative impact that the heavy rainfall has had. How do we quantify it? And then we're kind of in this winter agriculture season. So how does that play out in terms of production and productivity? How many more new variants might we have, and where might they come from? How might it impact us? That is, a kind of uncertainty, a risk that we have to just, acknowledge and somehow prepare for. There have been indications that within country there are reduced movements, at least if you use toll data as your main indicator there. It could be that people are going back to the old road and not spending on the toll, but we're just taking that as an indicator to, issues in relation to the destinations that persons would normally go to. And then the initial vaccine plans, as we all know, are not going to be widespread, and perhaps sensibly so, given the issues that I refer to in relation to the KPs. People are very skeptical. So what we're looking at is probably not very large growth numbers for 2021-22, but certainly taken all together, we probably will have a slower decline than we were. And it's indicating some level of resilience, and it's one of those probably organic types of resilience that we couldn't program for, but is becoming far clearer as we try and navigate and retool and rebound from the challenges that exist here. In terms of some of the parameters, though, because we're looking at models, and models are really driven by the assumptions. We will need for more growth to have just more coping. Beyond the mask wearing and the sanitizing, which certainly need to continue, individuals, businesses, even government will need to be able to cope far better with delivering services, offering services to persons, whether it's labor, capital, whatever it is. And as part of this, we are going to have to rethink how we are trying to digitalize the economy, certainly, or the society. Certainly the infrastructure is important. We need broadband. But that is not going to solve the problem. We really need to look at what is it that Jamaica itself, as a society that's unique on its own, need in terms of a needs assessment. How do you move this society digitally? Many persons will latch on to all the new gadgets, the new apps, as Prof has indicated, but is that really societal, or is it just persons who already have access? So we need a needs assessment for digitalizing the economy. What are the prerequisites? What are some of the things? Again, going back to knowledge, attitudes, practices, and we see it playing out with needs, right? In that, we were going full steam ahead thinking everybody was on board, and then we had to take a couple steps back, go back to the drawing board, redo the legislation. So it is an indicator to us that digitalization is going to require a far more broad-based, maybe alliance-based approach to get the entire society on board, because without that, then we are forced to basically stay at home and only engage with businesses that can deliver, that have online payments. And we know our issues with informality already, which I'll speak to on the other half. And so reorganization internally, all entities, the university has to do that. All entities have to think about how are we going to reposition ourselves, daycares, to deal with the reduced numbers, but still get education done, still get health done. How do you do it? Because there is just so much capacity with doing more of the same. So on the social fallout side, and this might be one of the, the things that Cabinet will grapple with most, is how do we deal with what will be the eventual outcome on the education side? If it is that, students are in essence, going back to, the so-called shift system approach where they come on one day and they're online on another day, and how are we going to address these issues? Some people say, well, we'll repeat a year or repeat 2 years, but these things, as we know from economics, there's no free lunch. It's going to cost something. Are we prepared? Do we understand? Can we even understand what those costs will be? And it's not a one-off cost. This will be, over the long term. The issues with informality, as I indicated, very important. In 2006, I think, or 2013, maybe the most recent data, Jamaican economy estimated to be about 50 or 60% informal. And so the thrust for digitalization is going to have to overcome basically what is a structural feature of our economy. So it's not just that we were all, formal and we're registered, so all we're doing is switching to a digital mode. We have to think about really seriously, how do we get people to, one, trust the system, sign up, use it? Because when we look at the studies on financial inclusion, what we find is most Jamaicans have a bank account, but most of them are not using it. So we can sign up, we can qualify, but will we utilize the mechanisms, or will gaps in the system facilitate continued informality and the other negative ills that we observe, for example, with the TRN system and the driver's license? And then most importantly is going to be the continued issue of violent crime and the drag that has on the economy, on economic activity, on the perceptions of new investments, depending on how they enter the system. It's a possible deterrent, so how will we grapple with that in 2021, given all the other things that we need our security forces to deal with? We're dealing with gun fines and, transnational crimes. How do we kind of split the effort in terms of, on the local side, how do we deal with that? And so in terms of the policy agenda for 2021, and I'm sticking to macroeconomic, this isn't certainly not, the fulsomeness of the economic policy agenda. But on the macro side, we've accomplished two things. From our economic program from 2010, we've been making strides to implement fiscal discipline, which is clearly important, one of those preconditions for growth. And recently, the central bank has been granted independence. And that independence should not be interpreted as, so now they can do anything they want. Certainly, it's actually the opposite, because now the minister will set targets for the central bank to achieve, and the central bank will have to give an account to the Jamaican people whether or not it is achieved. So if it is, how did they do it and what were the impacts? And if it was not, again, why was it not, and what will they do to do that? The missing part is now this independent fiscal authority, which our minister has indicated is on the cards for this fiscal year, I think, upcoming fiscal year. And what this gives to the Jamaican people is very important in the context that we're in now. Having come out of the IMF agreement successfully and to lots of acclaim, in the context of COVID, where we see the government trying to, balance livelihoods and lives and balance the books with those, we want to make sure that there's independent assurance that we are not going to have a run-up of the debt on a, let us say, willy-nilly scale, and that if we do need to acquire more debt or get into more debt, that it is being used for things that can help us to recover and to build more resilience, rather than just a continued run-up in the debt that requires, God forbid, other debt exchanges or other liquidity management programs similar to the ones that we've seen in the past. So at least the independent fiscal authority in this context kind of completes the circle. It's kind of like a trifecta where, yes, the minister is being responsible and is doing what they ought to do, but can we get that kind of independent assessment of to what end, what are the impacts, what have we given up, what have we gained from either decision that has been made? And it should also help the general public to understand better the budgeting process. What is government doing, okay, and what is it supposed to achieve versus what has it or will it? The broader agenda, I think, is going to be a combination of managing these market failures that I've indicated in the context of the crisis, whilst not running up the debt beyond what might need to happen. So we don't want to also, at the same time, we don't want to create further moral hazard, and we certainly don't want to introduce any adverse selections into the behavior of the society, so that we then end up with basically perverse outcomes from our policy decisions. So the end goal of the economic policy is going to have to be one that is built on a transformed set of processes that consider, one, the cultural nuances. As I've said, we can't just take digitalization as it was done, for example, in Estonia and bring it to Jamaica. It's two totally different societies, economies, structures, everything. And also we need to build in some redundancy. So now that we've gone through this low probability but high impact shock, how does this make us better responders, similar to how we know how to respond to earthquakes, how we respond when we hear an announcement of a hurricane? How do we build in and build up our system so that we can actually navigate such types of shocks in the future? What this means is that we're going to have to continue to prioritize the public goods, as well as the externalities that are positive and help the society to do better, and make sure that the negative ones, such as, you know, not wearing your mask, not sanitizing, are minimized as far as possible. So one of the things that I'm sure will be under consideration is, are we going to have more care packages, a la the one that was implemented in 2019 by the Ministry of Finance in collaboration with the other entities of government? Will we, because we know we need to protect the most vulnerable and also the near vulnerable, the near poor, the working poor. We have to do that. Those are some of the things that must be done. We also know that the health response is going to be front and center. What will be some of the items that will be prioritized here? We see some in the media, but is that what we need to do, or are there other priorities that need to be front-loaded in at least in Q1 of the new fiscal year? And then, as we've spoken, we can't avoid talking about education. How do we restructure, re-envision, reimagine? How do we change the way we do things? And all of that is part of the security building. We have the national security issues, but there are also border security and other issues that we will need to confront as we go into the agenda. And central to it, of course, is going to be the need to maintain fiscal discipline, but at the same time balancing that need with boosting economic livelihoods. We spoke about the subsistence economy, the informal sector. How do we maintain fiscal discipline whilst enacting or implementing, not just on the public sector side, of course, but also get the private sector involved? How do we plug persons into this kind of network? I suspect one of the strategies will be, continued infrastructure development. I have it as infrastructure plus, so, whether it's roads or drain cleaning or drain building, etc., rebuilding lost infrastructure. Those are things that are probably going to be central to the recovery effort. At the end of it, what we'll expect to see is a more resilient kind of recovery toolbox that we'll have, because this is in essence what I would suspect the average business person would have kind of grappled with over the past year. How do we stay active? How do we protect our staff and their families? How do we get to consumers? How do we keep producing? And so that is part of what, even for government, for the individuals, we have to continue to try to enable persons to be able to take hold of and implement in our economic agenda. And so that, I think, is what will be on the agenda as far as 2021, but we have to ensure that we don't lose sight of what we need to happen over the medium to long term. As Cabinet goes into retreat, yes, we have to fight fires. We have to out the fire. If our house is on fire, we certainly have to put it out before we go to work. But it is imperative that as we do that, we do so with that long-term view in mind, medium to long-term view. We can't lose sight of our overarching development goals. We have Vision 2030 developed by the PIOJ and multiple stakeholders. And then we have our global Agenda 2030 that Jamaica is a signatory to. which both of them are geared towards leaving no one behind. It is certainly possible that we can recover, but leave far more people behind than were behind in 2020 when we started on this road. Because what we want to do in making Jamaica the place of choice to live, work, raise families, and do business is to actually improve the livelihoods of everyone involved. So we leave no one behind, we achieve our goals, and our society is far more empowered to take on the next set of shocks. Thank you very much.
Thank you very much. Thanks very much, Dr. Clark, for taking us through a reality check on the economy and the economics around COVID-19. Just my reflection again to you spoke of market failure as a phenomenon here under COVID-19, and we know that, I suppose in well-functioning economies, one expect equilibrium in the market, et cetera, et cetera. But upon market failure, you say there needs to be government intervention. And my reflection and question is, I take Jamaica as a kind of, let me say for now, sort of case study in a way, from a regional perspective. I know regional countries vary a bit with the economy, but tourism is a common factor for all of our Caribbean, most of our Caribbean countries. And similar things perhaps may be happening in other Caribbean countries. But to what extent would you say our Caribbean governments, and maybe Jamaica as an example, have the capacity to actually intervene and really make a difference in the market at this time? And if COVID-19 continues to have this kind of impact for an extended period, it's already 1 year, almost a year, and we're going to 2 years, 3 years, how sustainable, assuming if governments can intervene and make a difference, how sustainable is that intervention? I mean, right now, President Biden just got sworn in 3 days ago, and he is launching I think it's $1 trillion COVID intervention, right? I take that as maybe a part of a government intervention to help balance things out in a similar way. Are we able, and do we have enough from a government intervention perspective in our part of the world to really sustain this? Or are we going to reach a point where we just, I don't know what you call it in economics, I call it crash. Everything broke down. So maybe you can speak a little bit about that.
Thanks. That's an excellent question. And as I indicated, this is part of the balancing act. We certainly cannot implement, even if it's $1 trillion Jamaican dollar, necessarily intervention without considering, as I indicated, all of the issues involved. I think the tourism industry certainly, as I showed on the data from Statin, certainly has taken a big hit. I mean, you just by the way how it is organized, you need to come to experience, and part of it is also influenced by external governments. If they shut down their airports, then in essence they can't come. So it is a big challenge. Ability to intervene on that level is probably going to be something that our governments would have to do regionally, and maybe even with the help of the United Nations or some kind of brain think tank that can, just as how we've gone through 10 months. Yes, we're in decline. There are declines quarterly, but we've seen the slowdown. Why? Because people have come back up. Stores have said, well, it's Christmas or nothing, and we have kind of built in some kind of recovery. Will that be able to be done? I mean, in the context, as you indicated, of our societies, I think we would maybe need a coalition, the association. You point me to the social economy. How can we as CARICOM better make our cases? And we have institutions within the region, I think, who stand at the ready. I think UNDP and there are other entities, the CDB, who can help us to make that international representation. And of course we have our Ministry of Foreign Affairs that can also. So it would certainly have to be a kind of United Nations, even in the lowercase, effort to help us to kind of navigate those waters, because it is an international phenomenon that slowed down in tourism. I think other areas, and even when you look at our intervention locally, the care program, SETCAS, BESHCA, yes, when you look on it per person, it's not a lot, right? But let's take the other view. How many hours did people stand in the line at the National Stadium to collect what we might think is not a lot of money? So a balancing act again, and I think certainly at the level that you're indicating, what we would be looking for, we would have to have maybe a coalition kind of approach to try and navigate those waters, the testing, verification or assurance that when you do a test in Jamaica or in St. Kitts or St. Lucia, it is legitimate, it is robust, the results will be, what we say it is. And so I think, I'm sure the center, I think we have a center for tourism resilience. These are some of the things that they're going to have to think about, but you will have to get the global community to kind of sign off on the Caribbean as, okay, these seeds are good. You can go and come back and we'll trust that you would have done or not done what we don't want you to do.
Yes, thanks for that response. And one of the things I observed too is that Dr. Clark speaks a lot about that connection between the health interventions and the economy. So, even there's a plea within her talk, as there was in Professor Figueroa's talk, as there was in Prof. Christie's talk, as there was in Dr. Sandra Betty-Jackson Betty's talk, for wearing your mask and following the interventions to just reduce the spread. So we see, we come right back to the core issue here of controlling this pandemic with the impact across not only the personal health issues, but our economic health issues. Certainly, colleagues, our Vice Chancellor, Sir Hilary, is very keen on the repositioning of the university, looking at education and higher education with respect to these changes. One could perhaps talk also of market failure in the context of education. And I think our UE, our one UE regionally, is well and ready and able to also take on these challenges. And this is part of why we're having a teleconference like this. So thank you for joining us. I want to thank again, especially our economist. Maybe I hope she feels at home amongst the medics. Right? We certainly welcome her. She's a part of our team. Thanks very much, Dr. Christine Clark. Thank you very much. Excellent. Welcome. We have heard a lot from this morning to this afternoon about the COVID-19 pandemic. We have refreshed your memory about the epidemiology. We have gone into some new issues. We have looked at the vaccine initiative, both the technology of the vaccine, the safety of vaccines, but also we looked at things like COVAX. You've heard new terms like COVAX facility, what's happening internationally and regionally. And we have looked at the clinical profile, a refresher of the clinical picture. And we heard some new things from Dr. Lorianne Fisher about post-COVID syndrome and the progression of what happens, beyond actually having the disease itself. We also heard about the variant strains, and that there's some new strains there from Dr. Sandra Betty-Jackson. And the economy was not left out, the economic projections. Maybe we talk about a new COVID economy. And some people are asking, at the start of the year, we said this is your COVID-19 making New Year resolutions. But I hear out there questions about when will all of this end? When will it end? Somebody talked about COVID fatigue, getting tired now. We're here today, we're giving knowledge from the University of the West Indies. We want to bring hope, we want to restore hope, we want to rekindle hope. And so we cannot leave without a projection of how we cope and how we manage amidst uncertainty. And no better person to speak on this topic than our well-known Professor Wendell Abel. And I'll share with you that he's now a veteran. I think, persons like Clive Lloyd and Chris Gale. People say, when will Chris Gale retire from cricket? Well, we have had Professor Wendell Abel on this team, this batting team, consistently from day one. And not only that, just like Courtney Walsh, Mikey Holding, Chris Gale, Brian Lara, all the great cricketers, people say, why, we want him back. We want to see him bat again. We want to see him perform. So, ladies and gentlemen, I'm very happy to introduce to you our Professor of Mental Health Policy here at the University of the West Indies, Mona, Jamaica, our head of the Department of Community Medicine, Community Health and Psychiatry, and a member of the UHWI COVID-19 Task Force, and a distinguished professor, humanist, a man of the community in all sense of the word, Professor Wendell Abel. Let's hear how he encourages us to keep hope alive amidst this pandemic. Prof. Abel.
Good afternoon. I deliberately struggled to take my mask off, and in doing so I asked, when will this all end? When are we going to be able to put the mask down? And the question I'm asked to answer is, when will this all end? And to encourage us to keep hope alive. So good afternoon, everybody, again. And before I start, I want to do a pulse check. So important to make sure that we are all alive. And in doing this pulse check, I want us in one sentence, just let us hear, how are you feeling? How are you coping? And so those of you listening on, you can just type something in the chat room and so on and give us your feedback. One sentence, how are you feeling? And I can imagine, for many of us, 2020 was a rough and tough year. In fact, as I navigated the year myself, I felt as if many times I was going on turbulent waters, uncharted. Never in our history have we ever navigated such water. There are times when it felt chaotic, fearful, painful, and the emotions continue. And I can imagine what you have all written. But the fact that we're all here this afternoon and we're all tuning in again for another pandemic conference, it means that we have survived. And so I want everybody to do the butterfly hug. And you're going to take your right hand, put on your left shoulder, left hand, right shoulder, and just tap yourself. Just be gentle. And as you do that, I want you to move into an attitude of gratitude and say to yourself, I have survived. Repeat that. And be compassionate with yourself. It's been a tough year. Just remind yourselves that I did my best. Everybody, I did my best. And I know that felt very good as we tapped ourselves, and we have to do more of that. Attitude of gratitude is so important. And as we sit where we are this afternoon, let's continue to count our blessings and remind ourselves we're not alone in this. Live now in the present. Want us to continue to focus on the here and now and accept what we can't control and focus on the things over which we have control. I'm going to start my presentation by sharing with us a study that we did here at UHWI Mona in August last year. We looked at the psychosocial impact of COVID among Jamaicans. And I'll just share with us some basic data. And what it showed is that 55% of our respondents, this was an online survey, admitted, reported anxiety symptoms. Another 55, about the same, reported depressive symptoms. What was interesting, only a few persons actually met the criteria for full depression, but people were having depressive symptoms. And what we found most interesting is that 97%, almost all respondents, said that they wanted psychosocial support. And this is what has also influenced the university to ensure that we have behavioral specialists on these conferences. And over the period, I also did a lot of presentations. And the anecdotal report suggested that we're having depression among the elderly. Professor Shearer would have touched on that. Depression among vulnerable groups. What was consistent throughout was that working mothers, we sometimes forget them. They were every time I spoke to a group, the working mothers were saying, we have a sense of being overwhelmed. They're working at home, they're supervising children, they have to become teachers because we sometimes forget them, but it has been a difficult passage for working mothers. Our data in mental health suggests that there's increase in substance use, and our children, many of them are having adjustment issues in many respects. For all of us, I think all of us are going through a grieving process. And as I've said before, grieving is a natural response to a loss. We have all lost something. whether it's our rituals, our routine, our ways of doing things. We've all lost something, and in the process, we grieve. In fact, I think some months ago, our dean said to us that just walking out of his office and he saw the place empty, he felt that something is lost, something is missing. And as we go through this grieving process, we have to remember that grieving is a normal and natural process. As you navigate these difficult times and you grieve, it's normal and natural to do so. And for many persons, they've had to deal with the crisis fatigue, the isolation, remote working, school closure, financial problems, illness, death, physical distances, limited social life, or work and worship, all have been disrupted, right? And we have to cope. And as we sit, I always remind us that it is okay not to be okay sometimes. And I want you to pause wherever you are and just to say to yourself, it is okay not to be okay sometimes. It is okay not to be okay sometimes. And I'm going to share with us a technique, so many persons anxious, depressed. This is one technique that I've used personally to just sustain me during these turbulent times. And it's a simple exercise, and many of you can go online and learn the techniques. But what I'm going to ask you to do, wherever you are, just sit. And you're going to plant the sole of your feet on the floor. Maybe you want to hold on to the chair. And what I want you to do is close your eyes and just breathe in gently through your nostril. Hold your breath for a little while and then breathe out through your mouth. And as you do that, just feel the air going in. Let's continue. Just breathe in, hold, out, gently. Just focus on the air going in. Just breathe in and out, gently doing so. And as you do that, I'm sure you begin to feel your body relaxing. Well, I'm not going to do a full run of this, but just want you to practice it. It works if you work it. At a very fundamental level, COVID-19 has been a major existential crisis. And I want everybody to repeat this, an existential crisis. And what it does as an existential crisis is that it has forced us to come to terms with our existence as human beings. We've had to, many of us have lost meaning and purpose and hope in life, right? For some persons, they've had to deal with death anxiety. I've had those moments, right? Especially when there are surges and I worry about myself as a doctor and all of that. And for many persons, they've had to deal with the loneliness that comes with the physical distancing, the elderly especially, people who are vulnerable. And so as we go through this major existential crisis, right, we question a lot of things in life. And for some persons, they find themselves in a situation of despair and there's not hope. COVID-19 indeed has been crisis. For some people, chaos, and other persons, change. And the question we ask ourselves this afternoon is, where is the hope? Is there hope in all of this, in the crisis, the chaos, the confusion, the turbulence, the change? Where is the hope? I don't know if I can answer all of that question, but knowing my imperfection, I want to remind us that as a therapist, as a psychiatrist, I'm not perfect, but I'm a guide. And so I'll try to guide you during these turbulent times. And I think most of us are familiar with this picture. It's illusion of change. As you look at it, what are you seeing? I'm sure some people, when you look at the white in the picture, you're seeing a vase or an urn. Other persons you're seeing, if you look at the dark session, you're seeing two faces, yes? And the point I'm trying to make in all of this is that as we look at change, right? For some people, because COVID is a period of significant change, some people are seeing crisis. And some persons are seeing opportunities and hope, yes? And I project this slide, and what does it read to you? Some people would say opportunity is nowhere. But if you look, it also says what? Opportunity is what? Now here. And opportunities like that sometimes when it's staring you in the face, we don't see it, yeah? And so Yeah, all the time I share this with us, that we have to reframe. It's so important for us to what? Everybody reframe, which is looking at things differently. Yes, this is period of chaos, confusion, change, right? But behind it, yes, there are crises, but there are tremendous opportunities and hope, right? And we have to keep looking for that. And so one of the first, is that we have to embrace the new, right? This new normal, right? The old is gone. We have to forget the past. Our world has changed. One of the obvious things is the digital transformation of our lives. 2 years ago, we're having a conference. We would be in a large lecture room, people traveling to come to the lecture. We never thought that we could do this, right? And as we have done so with other conferences and streamed all over the world with large numbers. In fact, this medium has given us the opportunity to reach more persons than we ever had. The digital transformation of our lives. Every day I speak to people who tell me, I remember one person told me she does wedding planning, and with COVID everything crashed. And she was able to switch to online marketing, sitting at home. And the stories are repeated every day about people looking for the opportunities and grasping them. This is also an opportunity for us to reset our lives as we seek purpose and meaning and hope in our lives, right? And I want everybody to literally press that red button mentally and just reset. It's a great opportunity to do that reset button, especially at the start of the year. It's an opportunity, wonderful opportunity to reconnect with ourselves, with others, and with our faith, yes? And one thing, gardening for me is a hobby. And over the past year, I have met so many persons who, in terms of reconnecting with themselves, have turned to nature, doing things together. They're more connected with their faith. A tremendous opportunity for us. And we're recognizing that these things are more important than a lot of the things that we have been accustomed to do. It has taught us to value social connection even more. And so I encourage us to continue to reach out to our family, friends, our faith. Remember the elderly, the sick, people living alone. And one of the things that COVID has taught us is that support matters. How people are important to each other, right? As people, we need people. It has taught us to do different things and to do things differently. And I want people to repeat this. Do different things and do things differently. Louder. Say it to yourselves. Do different things and things differently. There are so many of us during the period have reimagined ourselves. We have retooled ourselves and we have reset ourselves. And I often say, never waste a crisis. It's actually never waste a good crisis, but I don't know if I can say COVID is a good crisis, but never waste a crisis. It has taught us the value of personal responsibility and encouraged us to wear masks, wash hands, watch our distance. Our actions matter. Taught us the need to be positive, yes? It has taught us again how important it is for us to focus on our self-care. And I encourage us again, make sure you're getting adequate sleep, exercise, pay attention to your diet. In creating the hope, I want to encourage those of us who may be having difficult times, challenging times, to seek help. Remember, professional help is available. And I think one thing that the COVID crisis has taught us is the importance of mental health and behavioral health. And so those of you who may be struggling, having difficulty, seek help. Another thing that I've seen expanded over the past year, support groups. And so I now have patients or clients who will join a support group. They don't have to go to a physical location. They can join a group in Australia or a group in Indonesia or wherever they want in the world. Tremendous opportunities. And what has also increased is a lot of interventions, things such as hope interventions. You can go to see a therapy for that, or another therapeutic strategy that has come about is what we call meaning making. It's about doing therapy to make meaning of all of this chaos, confusion, and crisis. We also realize that there are lots of mental health apps that are now available online. And so especially when I have my young clients and I talk to them, they're the ones who've been educating me about these apps, Calm, Mood, many of them. Go online and look at these mental health apps. And if you notice, I've also highlighted the telephone. One thing that this crisis has taught us is that you don't necessarily have to travel to see your therapist anymore, right? Here in Jamaica, people travel from western end of the island, Montego Bay to Kingston. You can pick up your phone and do your therapy on phone, right? WhatsApp. And so tremendous opportunities there are in terms of just seeking help and providing care. And as I come to a close, I just want to remind us to be courageous. And I share with you a poem, an old poem. It says, question not, but live and labor, till your goal be won. Helping every feeble neighbor, seeking help from none. Life is mostly froth and bubble. Two things stand like stone. Kindness in another's trouble, courage in your own. I think for many of us, we realize that life, beyond all the material things, is that life is really, it's mostly froth and bubble. Disappear, goes like that. Two things stand like stone. Kindness in another's trouble, and courage in your own. And so I encourage us, be courageous. And so, you know, as we come to it's timely that we're at the beginning of another year, and I want everybody to create their own vision board. Grab a sheet of paper. You don't have to complete it today, but I want you to do it for this year. Look at the opportunities that exist. Look at your goals. Some of us, we may have to modify our goals. We may have to wheel and come again, as we sometimes say in Jamaica, right? But look at your opportunities, your goals, individually, for your family, for your team, for your organization. But we all need to do our vision board. And so this is an opportunity for us to revisit our vision board. And as I come to an end, I want us all to we're going to stretch our hands. Everybody, wherever you are, and I want you to stretch. We're going to send some energy across the country you are in, across the continents, across the globe, to your friends, family. Stretch your hands. And as you do that, I want you to join singing this song. Don't worry about a thing. Every little thing gonna be all right. I can't sing, but I know those of you sitting where you are will join me in singing. Don't worry. Every little thing gonna be all right. I know you're all laughing at me, but I can't sing. And so, as we come to a close, I just want to encourage us, keep hope alive. Better days are ahead. We've heard it. Vaccine is here. It's efficacious. We'll soon be here in Jamaica. Better days are ahead, and we're closer to better days. Thank you very much. And I encourage you to follow me on email, Twitter. That's my number. Have a wonderful afternoon, everybody. Better days are ahead.
Thank you very much, Professor Abel. Excellent way to end our conference or teleconference today. The encouragement, we say, when will it all end? What I'm hearing from Prof is that as it goes on, as it continues, we don't have to end our stuff and feel despondent and despair. We can continue with hope alive. What a gem set of thoughts we had this morning on a package. I don't know what was your best collection in Prof's talk, but I love that thing when he put up opportunities nowhere, and he really caught me. That is, opportunities now here. What a transformation from seeing like everything is gone, and then suddenly saying opportunity. And certainly a lovely, inspiring, poetic reference there. Life is like, let me see if I remember it, Prof. Life is like froth and bubble. That reminds me of Morbi, though, in Trinidad. If you drink, Trinidadians out there, if you drink Morbi, Morbi has a lot of froth and bubble at the top, but it's good stuff. Pepsi soda. Life is like froth and bubble. Two things stand like stone. Kindness in another's trouble and courage in your own. It's deep stuff, really, really, really profound. So I want to thank, on your behalf, again, our veteran batsman, Professor Wendell Abel, who has again taken the time to come and share with us words of inspiration and encouragement as we make our resolutions for the new year, and encouraging us to make positive resolutions, reframe, reset, restart going forward for 2021. Thank you very much again, Professor Abel. Thank you. It has been a full morning and part of your afternoon as we took on our teleconference, COVID-19 teleconference on the making New Year resolutions. We trust that you have had a good time with us this morning as we looked at a range of topics that we feel brings new knowledge, new perspective, new inspiration at the start of 2021 in continuing the fight for, our fight against the pandemic, against this virus. And we heard a number of interesting things. I certainly, there are a lot of things that have stayed with me, stuck with me through listening to all of our speakers. I remember Professor Figueroa saying that we must not forget the other conditions as we take on this pandemic. And he gave the example of TB causing over, million plus deaths per annum, even as we battle with the deaths from COVID-19. We have heard on the clinical syndrome, Dr. Lorian Fisher spoke about that for COVID-19 and what I would call the breaking news on what is happening now with the post-COVID syndrome, persons who have not even been in hospital but ending up back in hospital, and we're seeing a level of mortality and morbidity as post-COVID. The treatment options, we've heard the really excellent update from Dr. Metalor. The variant strains, Dr. Sandra Betty brought us up to speed with what's happening out there, worldwide and locally, and the management of our special populations. We need to keep that group in mind as we focus on improving the overall well-being of our communities. The question of vaccines, an excellent presentation on the different vaccines that are available. We looked at their safety, efficacy, and throwing the options out. But at the end of the day, I think we heard good news from Professor Christie that the vaccines are, overall, the safety profile is positive, and the efficacy is high, and what we need to work on now is the availability for us and accessibility. But certainly encouragement from many of our speakers for us to prepare for that COVID shot and be prepared to take that vaccine as soon as it becomes available. We had a excellent talk from Dr. Christine Clark on what COVID is doing to the economy, the question of market failure. And when I heard her talk about market failure, I'm thinking about we talk of multi-organ failure that COVID-19 brings to the physical being. And certainly it was interesting to hear, certainly I know the economists speak of market failure and the need for intervention, government intervention to make a difference. These are challenges that we face. But again, seeing the potential for regional collaboration, international collaboration in responding to the economic impact. And certainly our presenter on the well-being aspects of the pandemic, Keeping Hope Alive, we ended our talk with a call by Professor Wendell Abel to keep that hope, even though we say, when will it end? And I think what he's saying to us is that we need to adapt what he talked about, restore, repair, reboot, restart. It's a lot of reframing how we see this phenomena, and not to go down in the dumps, but to refresh ourselves. He gave us the deep breathing exercises and some wonderful poetry that we can reflect on. So I think as we leave today, as we leave our teleconference, we trust that we have presented an update that provides for you, for our those who attended, an entry into 2021 that we can reflect on our programs and project positively for the future. The take home for me in terms of resolutions are to continue to look at my own behavior in terms of the protective equipment against COVID-19, wearing the mask, sanitizing, distancing, doing the ABC. I call it now the ABC of COVID-19, just continuing to practice the ABC. The second resolution for me is to continue to believe the science, trust the science, interrogate the science. We are scientists here, certainly from the UE, but we want to continue to pay attention to the science as opposed to there's lots of misinformation out there on COVID-19. And as the condition persists, we heard Dr. Sandra Betty-Jackson saying we'll soon say it's endemic, which means that we're really living with it. But we are getting on top of it as we live with it. We have that potential to bring the science to bear on this pandemic. And so I'm prepared to get my shot. Professor Celia Christie is here, and she says as soon as she gets it, she can give it to me. And I'm not too sure like how Fauci and President Biden and all of these folks were on camera taking it. I don't think I want to be seen on camera when I take my shot. But I would take it, I promise you. So let me end by thanking, I want to thank everyone who contributed to this wonderful teleconference today. Our speakers, Professor Figueroa, Dr. Sandra Jackson Betty, Dr. Laurie Fisher, Professor Denise Eldemire-Shearer, Dr. Kelvin Metalor, Professor Celia Christie Samuels, Dr. Christine Clark, and Professor Wendell Abel for taking the time, agreeing, preparing, coming out to speak and present so well to our audience. I want to thank our staff from the Dean's Office, Ms. Unique Brown, Ms. Sharon Roberts, for their support, contribution, all of those who were working behind the scenes. I want to thank our Marketing and Communication Office, Ms. Gideon Martin and team, for helping us with the promotion and getting the word out. And I want to, as always, this is a big up. I have to say, this is not even just thanks, this is big up. The MITS team, the Mona Information Technology Services, the team that is involved in getting the communication going, keeping us on track, etc. Mr. Damian Brown, Ms. Shauna Spence, Mr. Andre Forbes, and Mr. Ishmael Preston for continuing to provide excellent technological inputs in having this teleconference come to the fore and for you to be able to enjoy it. I must say a special thanks to Professor Celia Christie, who is actually the driver of these teleconferences. She has the vision, she had it from day one, and she's continued to share that vision and push for us to get the information out there. So just thanks, everyone. My final thanks is to thank all of you who attended. We had a huge audience today. We were so encouraged to see the really, really big turnout again at the start of the year. And I heard people saying in the chat from all over the world, Caribbean, alumni, international, we thank you for coming. And we look forward to meeting with you again as we continue to perform our basic function at the University of the West Indies to teach, educate, and share the knowledge. Thank you so much, and God bless.